Hello everyone. So let us discuss most important questions which is expected to be asked in exam. With these questions, I would try to cover the entire topic of anesthesia in these few hours. So let us start with our first question. The question is, a 49 years old female came for elective minor surgery. She has a medical background of type 2 diabetes and COPD. Investigation shows that glycosylated HB is 5% and rarely requires salbutamol inhaler for her COPD. Under what ASA physical status we would classify her? So what is the importance of ASA physical status classification? So the first topic which I am discussing is ASA classification, a very expected question of exam. Now from recent last year, if you pick up the paper, there has been question on ASA grading, and I expect a question can be asked in your exam as well. Okay, so what is ASA classification? In pre-anesthetic evaluation, after taking the history of the patient, doing physical examination, seeing some investigation, we classify the patient in ASA classification or ASA grading. This classification tells us about the risk associated with surgery. So it tells us about the risk associated with surgery. Okay, so ASA classification tell us about risk associated with surgery, and we have 6 ASA grades. Okay, we have ASA grade 1, 2, 3, 4, 5 and 6. From 1 to 2, 2 to 3, 3 to 4, 4 to 5, 5 to 6. The risk associated with surgery is gradually increasing. So it is telling us risk associated with surgery. So what is ASA grade 1? ASA grade 1 is a patient coming for surgery having no comorbidity. He is a healthy patient, has no comorbidity. Once separated, he would become a normal person. So ASA grade 1 is no comorbidity. Patient having no comorbidity. ASA grade 2, patient is coming for some surgery, has a comorbidity, but it is a controlled comorbidity causing no limitation on his any activity, his normal day-to-day activity or his strenuous activity, nothing is affected. So patient is having a mild systemic illness which is thoroughly controlled by medication. So mild systemic illness. Okay, so this is our ASA grade 2. ASA grade 3. ASA grade 3, patient is having a systemic illness, is on medication, normal activity, no issue. But on strenuous activity, the patient becomes symptomatic, like patient has angina, it's a stable angina, but on walking for 5-6 kilometers, patient starts complaining of chest pain. So normally patient doesn't have an issue, but when patient performs some strenuous activity, patient becomes symptomatic. So it is moderate to severe systemic disease. So moderate to severe systemic illness. Okay, so moderate to severe systemic illness. ASA grade 4. The systemic illness is life-threatening. Systemic illness is not compatible with life. His normal activity also patient cannot perform because of his systemic illness. Patient is symptomatic even at rest. So life-threatening systemic illness, right? ASA grade 5. ASA grade 5, surgery is the only option for survival. ASA grade 1 to 4 is different, 5 is different. So surgery is only option for survival. Option for survival. ASA grade 6, brain dead patient. The patient who are brain dead, they are only there for organ, if we have selected them for organ transplantation. So this is ASA grading 1, 2, 3, 4, 5 and 6. 1 to 4 very commonly asked in exam, and if I see our question, patient has come for some minor surgery and patient has type 2 diabetes and COPD. So has a systemic illness, but the systemic illness is not symptomatic, it's thoroughly controlled. Patient does not require much of medication. His diabetes also seems controlled, his COPD also seems controlled, and no clinical feature is described. So, patient belongs to ASA grade 2. So, our patient is ASA grade 2. So, this is the answer for my first question. So, important question, ASA grading is very important from exam point of view. Remember, ASA grade 1, no comorbidity. ASA grade 2, mild systemic illness. ASA grade 3, moderate to severe systemic illness. ASA grade 4, life-threatening systemic illness. Alright. So, I hope this is clear. Now, in pre-anesthetic evaluation, another important question can be asked on investigations. What are the relevant investigation we have to do? So, if I read this question and then I'll tell you a few more things about this. The question is, a 56 years old male with a history of percutaneous coronary angioplasty, that is PTCA, done 5 years back, is posted for laparoscopic appendicectomy surgery. All of the following investigation should be done in him except. So, patient is posted for lap appendicectomy and patient has some cardiac history. So, the question, if I simplify the question, in a cardiac patient posted for surgery, what are the investigations required? So, let us first talk for a normal patient posted for surgery, not having a cardiac comorbidity, what are the investigation required? So, for a normal patient who doesn't have a comorbidity, what in routine investigation we get done? So, we get done a CBC, that is complete blood count. We get done the urea creatinine to see the renal function. We get done the let's say ECG if the patient is a female patient and above 40 years. So, ECG, and if female above 40 years, and ECG if it is male above 45 years, and we get serum electrolyte done. Serum electrolyte, that is sodium and potassium. Now, this is enough for a normal patient. We don't do anything more than that. In some patient may not this normal investigation or may not be also required. In patient with cardiac comorbidity, cardiac disease, what extra investigation apart from these we will get done? What are the extra investigation apart from these we will get done? Okay. So, in patient with cardiac comorbidity, the extra investigation which we will get done would be the echocardiography, stress echocardiography. Now, this stress echocardiography, that is putting the patient to some physical activity like treadmill and seeing the heart responding toward that or not, that is the exercise stress testing. Or if patient cannot perform a treadmill test, we can go for pharmacological stress testing. But stress echocardiography is the best investigation to know the current cardiac status of the patient, right? Just a baseline rest echocardiography is not of much help. But if in the question echocardiography is mentioned, stress echocardiography is not mentioned, we can go for just echocardiography also as an answer, which the investigation we will get done. So, this echocardiography is one investigation which is very important for us to get done. Okay. So, the patient had a cardiac illness and now what are the investigation we have to get done? CBC, normal patient also. So, every patient we get a CBC done. Let's say this will be done. Stress echocardiography, yes, this is a cardiac patient. We would get a stress echocardiography done. Angiography. Now, coronary angiography is an invasive cardiac investigation, gives no added benefit in a patient. It does not give us much information which we require, right? See, angiography has only role for the CTVS surgeon if the patient is posted for CTVS surgery, posted for CABG surgery. So, angiography has no role, it has no role. Studies have shown that by angiography, if we know a particular area of heart has less blood flow, it is not necessary that during stressful period, that particular area would undergo any ischemia or infarction. Any other area of heart can also undergo. So, knowing the getting the report of angiography will not give us any added benefit. So, we never get it done. So, angiography, no role. Urea creatinine, we get it done. So, what is the answer? The answer is C. Coronary angiography is not done, except is it there, right? So, this is important. These are the normal investigation for normal patient. In cardiac, extra what? Stress echocardiography. Okay, next question. Identify the image given below. Now, remember, in pre-anesthetic evaluation, Apart from taking history and doing physical, general examination, systemic examination, one very important thing which we anesthesiologists get done is airway evaluation. Now, there are a lot of things we get done in airway evaluation. We concentrate on the history of previous anesthesia exposure to evaluate the airway, few more other parameters. We do some physical examination, lot of things. No single test tell us about any is a good predictor, I must say. So why do we do the airway evaluation? Airway evaluation is done to predict difficulty in intubation or mask ventilation. So airway evaluation is done to predict the difficulty in intubation or mask ventilation. And as I said, no single test is good predictive. So multiple tests are done, multiple evaluation is done. So forget it, multiple evaluation. What for your exam you have to remember? You have to remember a very important evaluation. Though sensitivity of that evaluation is not very good in predicting the difficult airway, but for exam point of view, very commonly asked, Mallampati grading. So what is this Mallampati grading? So identify the image given below. So what is this image? What is this image? What is happening in this image? This is an image of Mallampati grading, class 1, class 2, class 3 and class 4. So in option was ASA grading, we have discussed. We have ASA grade 1 to 6 and it is used to assess the risk, and there is no image for that evaluation. AHA grading, American Heart Association grading, to predict morbidity and mortality in cardiac patient. Mallampati scoring. So this is something called Mallampati scoring. Konmark-Lehane grading. Konmark-Lehane grading is grading of glottic opening on laryngoscopic view. This is not a laryngoscopic view. I open my mouth, take the tongue out, and whatever you see is Mallampati grading. So I have not put a laryngoscope to see the structure. So this is not a laryngoscopic view. It is done in pre-anesthetic checkup room. It's a pre-anesthetic view. So Konmark-Lehane is also a predictor of difficult airway, but it is a laryngoscopic view of glottic opening. When we do laryngoscopy, how much the glottic opening is visible, that is graded in 4 grade, and that is what is Konmark-Lehane grading. So Konmark-Lehane grading is grading of laryngoscopic view of glottic opening. This is grading of laryngoscopic view of glottic opening. Okay. So this is your Konmark-Lehane grading, important. Okay. So this image which has been given is of Mallampati grading. So remember, what is Mallampati grading? So as I said, Mallampati grading is pre-anesthetic view of oral cavity, pre-anesthetic grading to predict difficulty in intubation. So this is pre-anesthetic evaluation to predict difficulty in laryngoscopy and intubation, right? So Mallampati grading is pre-anesthetic evaluation to predict difficulty in laryngoscopy and intubation. And as I said, we have 4 Mallampati, grade 1, grade 2, grade 3 and grade 4. Okay. So if you see this class 1, I am able to see most of the structures of oral cavity, hard palate, soft palate, uvula, pillars. In class 2, pillars are not seen, tonsillar pillars are not seen, other structures are seen. In class 3, hard and soft palate is seen, nothing else is seen. And in class 4, only hard palate is seen. So am I interested in these structures? Actually no, what I am interested is in grading the tongue with respect to oral cavity. So Mallampati grading is grading of size of tongue with respect to oral cavity. So when I do laryngoscopy, if tongue is big, it will not go out of my way and laryngoscopy and intubation will become difficult. So 1 and 2, right, in which we have a smaller tongue, no difficulty anticipated, no difficulty in intubation. 3 and 4, large tongue, so difficulty is anticipated. So, it can be difficult intubation. It can be difficult intubation. Got it? So, remember this. This is Mallampati grading. Okay. Next question. Just a practice question on Mallampati grading. Among the following, which condition Mallampati grade 4 can be seen? In which condition Mallampati grade 4 can be seen? I told you, the only way to do Mallampati grading, ask the patient to open his mouth, take the tongue out, and then try to see the structures of oral cavity. Okay. Now, in Mallampati grading, if the structures are clearly seen, that means tongue is not obscuring the view, patient has a small tongue. But in 3 and 4, tongue is obscuring the view of structures of oral cavity and we have a large tongue. So, which condition Mallampati grade 4 is seen? Options: large tongue, post-burn contracture of neck, fracture mandible, TM joint ankylosis. Now, all the 4 options in the question are difficult airway. They will cause difficult airway. But what does Mallampati grade 4 predict? It predicts the patient has a large tongue. Okay. So, Mallampati grading is predicting the large tongue. Remember, so this is the only possible question on Mallampati grading. The image based question. Then what does Mallampati grade do? It's a pre-anesthetic predictor for predicting difficulty in intubation. Then we have 4 grade, 1 and 2, normal tongue, no issue, 3 and 4, large tongue. So, it is predicting the large tongue. This is the only possible question on Mallampati grading. Okay. Okay. So, now coming on next question. So, this is again an image of Mallampati grading which I brought for you. Keep this image in mind. One more thing very clear. For predict the Mallampati grading, the tongue has to go out of the oral cavity. Tongue has to be out of oral cavity. If tongue is inside the oral cavity, it is not Mallampati grading. If tongue is outside the oral cavity, right, then only Mallampati grading is being done. Okay. Okay. Next question. A 40 years old female posted for laparoscopic cholecystectomy. She has a history of hypertension, ischemic heart disease. So, she has a multiple comorbidities. She is on multiple medication for both condition, for ischemic heart disease and for hypertension. So, she is on atenolol, Lasix and clopidogrel. All of the following medication needs to be stopped prior to surgery except. So, there are some medication needs to be stopped prior to surgery and there are some medication which is continued throughout the surgery. So, what are the medications which are stopped prior to surgery? What are the medications which we continue throughout the surgery? We need to know. Okay. So, very quickly we will just discuss orders regarding previous medication. Orders regarding previous medication, right? Orders regarding previous medication of the patient. So, if patient is hypertensive and on oral antihypertensive medication, if a drug is started as an antihypertensive, it has to be continued till the day of surgery. So, all oral antihypertensive. So, all oral antihypertensive. This is continued till the day of surgery. Till the day of surgery. Okay. Then oral hypoglycemic agent. Oral hypoglycemic agent. Okay. So, if a patient is on oral hypoglycemic agent like your OHAs, like your metformin, etc., what do we do? It depends upon the type of surgery. If it is a minor or moderate surgery, what we do? Simply we ask the patient to not to take the last dose, quit the last dose. So, minor to moderate surgery, quit last dose. So, only the last dose has to be stopped prior to surgery. If it is the major surgery, then we ask the patient to quit the last dose and put the patient on insulin. See, you are keeping the patient NPO prior to surgery. So, if we will not stop the oral hypoglycemic agent, patient will go into hypoglycemia. So, we have to stop it. Major surgery, we don't want blood sugar fluctuation. So, we put the patient on insulin. Remember this. Okay. Then, anti-epileptic antipsychotic, antidepressant, these drugs. Now, these drugs, remember, we have to continue it to the day of surgery. So, we continue till the day of surgery. If in this any drug we have to stop, there are two drugs we have to remember: lithium, which we stop 24 hours prior to surgery, and tricyclic antidepressant, which we stop 3 weeks prior to surgery. Okay? Then apart from this, we need to know steroids. If a patient is on steroid, what do? We continue the steroid with a perioperative supplementation. So, if a patient is on steroid, we continue with perioperative supplementation, right? So, we continue the steroid with perioperative supplementation. So, just for steroid, you have to remember this. Got my point? Okay. Then, guys, some anticoagulants we need to know, which are asked in exam. And in our question also, we have clopidogrel, which is used as anticoagulants. So, some anticoagulants. Just remember two important anticoagulants, aspirin and clopidogrel. So, a lot of patients would be on aspirin and clopidogrel. Aspirin, we continue till the day of surgery, and clopidogrel, we stop 5 to 6 days prior to surgery. 5 to 6 days prior to surgery. So, remember, clopidogrel is stop, aspirin is continued. So, these are the minimum drugs that you have to remember. So, coming back to our question, patient was on atenolol because patient was hypertensive. So, all antihypertensive is continued till the day of surgery. Now, patient was on Lasix, which was also for the hypertension. It has to be continued till the day of surgery. Patient was on clopidogrel, and aspirin. Now, aspirin can be continued, but clopidogrel has to be stopped. So, clopidogrel has to be stopped. So, all of the following medication needs to be stopped prior to surgery, or needs to be, I mean just correcting the question, all the following medication needs to be continued prior to surgery except. So, which has to be stopped? Simple, which medication has to be stopped? So, atenolol has to be continued, Lasix has to be continued, aspirin has to be continued. So, what we have to stop? We have to stop clopidogrel. Remember, so clopidogrel is stopped 5 to 6 days prior to surgery. Got it? So, this is an important question. Next question. Again, a very important question on pre-anesthetic evaluation. Question related to nil per oral status, NPO status of the patient. Okay? A diabetic patient posted for elective laparoscopic surgery. Which is the correct recommendation regarding the NPO status of the patient? So, diabetic patient is posted for surgery, and which is the correct status regarding NPO status of the patient? So, what do we need to remember? Why do we keep the patient NPO prior to surgery? To prevent risk of aspiration, to prevent risk associated with aspiration. So, prevent the risk associated with aspiration. Got my point? So, if my patient has been posted for elective surgery, we have to keep the patient NPO, irrespective whether I am giving general anesthesia or regional. So, it may come in your mind that if patient is to be given regional, there is no risk of aspiration. Why should we keep NPO? Well, any anesthesia, GA or regional, no doubt, elective surgery, we have to keep the patient NPO. Even in regional, we take the precaution and keep the patient NPO, because if it gets converted into GA, if it fails, or if some complication happens, we need to keep our patient prepared, prevent any aspiration to happen. So, prevent the risk of aspiration, NPO is must. So, how do we decide the NPO hours? So, just remember this small table. This is the ASA fasting guideline, the American Society of Anesthesiologists fasting guideline, which we Indian society also follow. So, clear fluid, breast milk, infant formula milk, non-human milk, light meal, heavy meal. I have divided everything. So, heavy meal, full fatty meal, we need 8 hours of NPO. Light meal like your dal khichdi or curd rice, 6 hours NPO. Now, any infant formula food or non-human milk. Again 6 hours NPO, right? So 6 hours, don't get confused, 6 hours, okay? Only for breast milk, we keep the NPO status 4 hours. And for clear fluid like water, tea without milk, coffee without milk, 2 hours NPO. So if I just divide it for adult and pediatrics, adult 8, 6, 2, pediatric 8, 6, 4, 2, 8 both for full fatty meal, 6 for liquid diet, for non-human milk, for infant formula feed, 4 hours for breast milk, and 2 hours in both for clear fluid. And irrespective of comorbidity of patient, type of surgery, if it's an elective surgery, this is the only guideline which we follow. So no confusion on the guideline. We do not change the guideline for any patient, right? Okay, so a diabetic patient posted for elective laparoscopic surgery, what is the correct recommendation regarding the NPO status? Now here, the type of food is not mentioned. So what we will do? 6 hours, 8 hours, 12 hours, NPO not required. So if the type of food is not mentioned, go for answer as 6 hours, because we give our patient direction. We take a light meal 6 hours prior to surgery. Only if the type of food is mentioned, how many hours NPO for clear fluid, then answer 2 hours, or how many hours NPO for full fatty meal, then answer 8 hours, or child was exclusively on breastfeeding, how many hours NPO, then answer that we'll ask the mother to give the last feed 4 hours prior to surgery. Here nothing is mentioned, answer has to be 6 hours. If 6 hours is not in the option, go for answer as 8 hours. So this is how you approach. Okay, now coming on the next question. So whatever I discussed till now were the questions from the first topic, pre-anesthetic evaluation, and these are the most important things which we need to cover in pre-anesthetic evaluation, that is the ASA grading, Mallampati grading, orders regarding previous medication, and orders regarding NPO status. And also I have given you one question on investigation, which I think can be asked because it has been asked in some of the previous exams. So these are the something which are most important subtopics of the topic pre-anesthetic evaluation. Now let us discuss the next topic question, monitoring questions. So question, a 27-year-old female posted for laparoscopic cholecystectomy. All of the following monitors need to be attached except. So when we give anesthesia, there are certain intra-op monitoring that we have to get done. So there are some mandatory intra-op monitors. So guys, let us talk about a little bit about the monitoring. ASA recommends, the American Society of Anesthesiologists recommends that there are 5 mandatory monitors. So 5 mandatory monitors. Okay. So we'll talk about these 5 mandatory monitors. 2 desirable monitor, and rest all are other monitor. So let us talk about 5 mandatory monitor. What are the mandatory monitor? The 5 mandatory monitor: ECG, then non-invasive blood pressure monitoring, then capnography, then pulse oximetry, and your temperature. So these are our mandatory monitor. Any patient undergoing any type of surgery, irrespective of type of anesthesia, these 5 monitors we have to attach. Now when a patient is under GA, there are 2 extra desirable monitor. One is your BIS monitoring, that is bispectral index, and other is your neuromuscular monitoring. Okay, so these 2 are desirable monitor. BIS monitors intra-op awareness, and neuromuscular monitoring monitors the adequacy of muscle paralysis, and anything other comes under other monitor, like your invasive blood pressure monitoring or your transesophageal echocardiography. They all come under others monitor, and these others monitor, they are attached according to the type of surgery and according to the comorbidity of the patient. And these 7 monitor mandatory and desirable. It is attached irrespective of the comorbidity, irrespective of the type of surgery. Okay, so let us see. The patient is undergoing lap chole, which is a normal surgery, and patient is no comorbidities is defined in the patient. So what monitors we should attach? We should attach this 5+2 monitors, because lap chole is done under general anesthesia. So capnography, yes, it is the mandatory monitor we will attach. Neuromuscular monitoring, yes, it is a desirable monitor we will attach. BIS, yes, it is a desirable monitor we will attach. CVP, central venous pressure monitoring. CVP comes under other monitor, and it is attached only if the patient has a cardiac disease or if the patient has a renal dysfunction. So this patient doesn't have anything of that sort, so this monitor should not be attached. So this is the answer. Got it? So answer is CVP monitor. You will be asked question like this only. Normal surgery, normal patient, what monitors should be attached? Remember, 5 mandatory plus 2 desirable if we give GA. And if we are not giving GA, any other anesthesia, only these 5 monitors, mandatory monitors has to be attached. So keep it in mind. Okay? Okay, next question. This kind of graph can be seen in all of the following condition except first, what is this graph? This is a capnograph. Capnograph. What is capnograph? Capnograph is graphical representation of expired carbon dioxide against time. So this is graphical representation of expired carbon dioxide against time. Okay. So expired carbon dioxide against time. Got my point? Okay. So this kind of graph in which the EtCO2 is increasing is seen in all of the following except, okay, ventilatory malfunction, hypoventilation, hyperventilation, malignant hyperpyrexia. So I will come on this question in a moment. Let us first talk about capnography. As I said, what is capnography? Capnography is a graphical representation of expired carbon dioxide versus time. Okay, it is attached between the airway of the patient and the circuit. So we attach capno between airway and circuit. So whether the gas goes from the machine into the airway of the patient, the inspiratory gas, or the expiratory gas from patient through capno into the circuit, both passes through this capno, and this capno has the ability to recognize carbon dioxide. So we all know the expiratory gas only has a carbon dioxide. So we get a graph of carbon dioxide against time. So this is a CO2 graph against time. Okay. When it is touching the baseline, mainly the patient is in inspiratory phase, and as it is increasing, the expiration is happening. Okay. So this is CO2 graph against time. Two things we have to see. One, the shape of the graph, which is called capnogram, and other, we have to see the numerical value, the normal and tidal CO2 value, the numerical value, which is in between 35 to 45 mm of Hg, right? 35 to 45 mm of Hg, got it? So this is the normal expired carbon dioxide value which we need to know. Okay. Now guys, if the value decreases below 35 or if the value increases beyond 45, there is a problem. Okay. And since CO2, this graph, coming of this graph depends upon three things: CO2 production in the body, CO2 being carried by the blood, and CO2 getting exchanged. So it depends upon the metabolism, which produces CO2, circulation, which carry CO2, and ventilation, through which the CO2 is exchanged. So in the body, carbon dioxide will be produced, it will be carried by the blood, it will be exchanged by the ventilation. So it depends, the CO2 graph depends on all these three things. So any problem happens in this, the CO2 graph can decrease or increase. CO2 can be less than 35 or more than 45. If metabolism, CO2 production in the body will increase. If the CO2 production increases, then EtCO2 value will increase. So here the value is increasing. This is 40, 45, and now it is becoming 50, 55. So it is increasing. So maybe hypermetabolism. So metabolism is increasing. What are the most common causes of hypermetabolism? Hyperthermia, shivering, etc. And one sinister cause of hypermetabolism which we need to remember is malignant hyperthermia. So CO2 production will increase in a very important condition, malignant hyperthermia. Okay. If CO2 is decreasing, it will be hypometabolism. Okay. Now, if the circulation is increasing, no change in CO2 will happen because there is a fixed CO2 produced in the body. But if the circulation decreases, the CO2 value will decrease. If the ventilation increases, hyperventilation, CO2 will go out of the blood very quickly. So CO2 pressure in the blood will decrease, and that is what is depicted in the expired carbon dioxide. That is what is getting exchanged. So what will happen? The EtCO2 value will also decrease. So in case of ventilation, in hyperventilation, when the patient is breathing more than normal times, the CO2 decreases in the blood, and this whatever CO2 is in the blood, that is what is depicted in expired carbon dioxide. So EtCO2 also decreases. Hypoventilation, when we breathe less than normal time, CO2 increases in the blood and EtCO2 increases. Got it? EtCO2 increases. So guys, in this CO2 graph is increasing. So what could happen in increased EtCO2? Metabolism can increase, or ventilation decreases. Ventilation can decrease, that is ventilation malfunction can happen. So ventilatory malfunction, yes. Hypoventilation, yes, when ventilation decreases in ventilatory malfunction. Hyperventilation, no. In hyperventilation, the CO2 will decrease, it will not increase. Malignant hyperparexia, yes. In increased metabolism, CO2 can increase. So answer is hyperventilation. Got it? So important, answer is hyperventilation. If the same graph was like this, if it was decreasing, this means patient is undergoing hyperventilation or hypometabolism or hypocirculation. So circulation decreases, metabolism decreases, the graph decreases. The ventilation increases, the graph decreases. Got it? Ventilation increases, graph decreases. Ventilation decreases, that is hypoventilation, the graph increases. And opposite happens with metabolism and circulation. Metabolism decreases, EtCO2 decreases. Metabolism becomes more, EtCO2 increases. Circulation decreases, EtCO2 decreases. So opposite if direction, the CO2 moves to ventilation, and in the same direction the CO2 moves to circulation and metabolism, right? With decrease in EtCO2, and with increase in EtCO2 for metabolism and circulation, right? And for ventilation, opposite, right? Opposite. So just keep it in mind, okay? Easy way to remember. Next question. A 40 years old patient in respiratory distress is intubated. The most likely cause of this capnography obtained just after laryngoscopy and intubation. So what is happening in this capnography? Now CO2 is gradually decreasing and touching the baseline. So after intubation, the CO2 1 or 2 waveform was there, and then it touched the baseline. So CO2 became 0. What would be the most probable cause after intubation? The CO2 becoming 0. This means that our endotracheal tube is not in the trachea. No expiratory gas is we are able to sense. That's why CO2 is 0. It is most probably in esophagus. So it is most probably esophageal intubation. Guys, the reason why capno came in clinical picture, why it was discovered, was for the confirmation of correct position of your endotracheal tube in trachea, right? So capnography is the best indicator, best monitor to tell us about the correct placement of ET tube in our trachea. If the ET tube is in trachea, we would get a proper graph. And if the ET tube is in esophagus, we would get a flat line. So Capnograph is best monitor to predict correct placement of ET tube, to predict correct placement of endotracheal tube. Got it? So, if it is properly placed, then only we will get a proper graph, otherwise we will get a flat line. So, when I am getting a flat line after intubation, it is esophageal intubation. What are the other options? Partial obstruction of ET tube. In partial obstruction of ET tube, there would be change in the graph. We would not get a flat capno. I will show you in further questions what is the change in the graph. Pulmonary embolus. In pulmonary embolus, we would see a sudden fall in the graph of the capno, but it will not touch the flat line. It may touch the flat line, but at least 1 or 2 graphs should be normal, right? And after putting the tube, suddenly pulmonary embolus will not happen until and unless surgery has started. Mild bronchospasm. Again, there would be a change in the graph shape, but it will never touch the flat line. Okay, so it is esophageal intubation. Okay, so remember, esophageal intubation, we get a flat capnogram. Okay. Tracheal intubation, we get a proper graph. Got it? Okay. Next question. This is an image with image given to marked on the EtCO2 value 40. What it is? So, what does this value represent? As I said, the expired carbon dioxide, right? What does it represents? This represents PaCO2. PaCO2, the normal value 35 to 45 mm of Hg. EtCO2, the normal value 40 to 45 mm of Hg. So, what is this representing? This is representing end tidal carbon dioxide. Expired oxygen? No. End tidal CO2. It is representing end tidal CO2. See guys, this entire graph, right, is the CO2 graph against time, but the value which we are seeing is the maximum expired value, the end tidal value, right. So, the value is not the mid value, not the baseline value, it is the maximum expired carbon dioxide value. So, it is end tidal CO2. Okay. Pressure of gases while breathing? No, incorrect. Inspired oxygen? Incorrect. So, it is end tidal carbon dioxide. So, this value. Okay. Next. What does following capnograph recording represents? So, change in the graph shape. As you can see, this is a normal graph. Right? Now, there are few abnormal graphs which we need to remember. Now, first abnormal graph which we need to remember is, if the shape of graph is like this is called shark fin pattern. The group of sharks swims and with their fin above the surface of water. This is what is shark fin pattern. So, this shark fin pattern, right, this is shark fin pattern is seen in mild to moderate bronchospasm, obstruction. Complete obstruction, there would be a flat capno, but mild to moderate bronchospasm, we would get this kind of graph. So, this kind of mild to moderate bronchospasm we can get in COPD patient, we can get in bronchial asthma patient, or this graph we can also get in partial obstruction of the tube, partial obstruction of ET tube. Okay. So, this is called shark fin pattern which we have to remember. So, this is a graph which is shark fin pattern. So, what does the following graph represent? Asthma, spontaneous extubation, raised ICT, air embolism. Well, it represents asthma or COPD or bronchospasm, that is partial obstruction. Spontaneous extubation, we would get a flat capno. Raised ICT, in raised ICT, there would be no change in the capno, and air embolism, we will get a sudden fall, got it? So, this is our asthma. Okay. Next, an 85 years old lady with history of fractured neck of femur During general anesthesia under halothane anesthesia for internal fixation of the fracture suddenly develops severe hypotension, bradycardia, capnogram, shows a sudden fall of end-tidal CO2, the most probable diagnosis is. So, this line we have to remember, this line shows a sudden fall of end-tidal CO2, right? Sudden fall, right, of end-tidal CO2. What does it represent? So, this is a normal graph and we get a sudden fall of end-tidal CO2. What does it represent? When you see this word sudden fall, the only thing which you have to diagnose is embolism. Now, what is embolism? Embolism is that any emboli, which could be air, which could be fat, which could be thrombus, anything going into pulmonary circulation. So, this is, let us say, your pulmonary circulation. This is your, let us say, pulmonary circulation, okay, and emboli goes into pulmonary circulation. So, it goes into pulmonary circulation here and there. So, what happens? The blood flow stops, right, blood flow stops. So, when the blood flow stops, the exchange of O2 CO2 also decreases. So, we get a sudden fall of end-tidal CO2. This is a most important line to diagnose embolism, and when you see this, the only answer has to be embolism. So, in embolism there is a sudden fall of CO2, okay, keep it in mind. Okay, next question. A 62 years old patient was operated under general anesthesia. He was being given propofol, fentanyl, vecuronium during maintenance of anesthesia. After reversal from anesthesia, patient had inadequate muscle power. Which monitor should be useful in assessing the muscle power of the patient? So, option bispectral index, neuromuscular monitoring, EEG, motor evoked potential. What is bispectral index? This monitor monitors depth of anesthesia. This monitors depth of anesthesia, that is the consciousness level of the patient. So, it monitors depth of anesthesia. Here we are talking about muscle power, okay. The muscle power, patient, we paralyze the patient. So, the drug which acts on neuromuscular junction, they affect the muscle power of the patient. So, to monitor the neuromuscular junction would be our target to assess the adequacy of muscle power. So, neuromuscular monitoring is what we do to monitor the adequacy of neuromuscular blocker. So, neuromuscular monitoring is done to see the adequacy of neuromuscular blockers, right. So, answer has to be neuromuscular monitoring. EEG is monitored in neurosurgeries, as neuromonitor. Motor evoked potential is also a neuromonitor. So, these two are neuromonitor. Neuromuscular monitoring monitors the adequacy of muscle paralysis, and that is routine monitoring, the desirable monitor which we do under general anesthesia, and this monitors depth of anesthesia. So, answer is neuromuscular monitoring to see the adequacy of muscle power after reversal from anesthesia, okay. Now, see this image. Identify the nerve being tested with the following monitoring procedure. Now, what is this monitoring procedure? First, you have to recognize that. Now, this is neuromuscular monitoring. Okay. Now, this is your nerve, this is your muscle, and this is your neuromuscular junction. For muscle contraction, the stimulus passes from nerve and muscle end plate is depolarized because of the release of acetylcholine and attachment of acetylcholine to the nicotinic receptor present on the muscle end plate, and as a result of depolarization we get a contraction. We go give a patient neuromuscular blocker. So, we give neuromuscular blocking agent which stops this transmission and we get a paralysis. So, to see the effect we need to monitor this neuromuscular junction. So, I have given neuromuscular blocking agent, whether it is working or not, whether reversal from it has happened or not, we can only see by seeing the effect on by monitoring the neuromuscular junction. And how can we monitor the neuromuscular junction? By monitoring a nerve and the muscle innervated by it. So, what is monitoring is happening in the image is neuromuscular monitoring. Which nerve is getting monitored? This is the course of ulnar nerve. So, on the course of ulnar nerve, we put 2 electrodes and we stimulate that ulnar nerve through this stimulator, nerve stimulator, and we see the response in the adductor pollicis muscle. Either we see it visually, a contraction, or this mechanograph measures it. So, this is neuromuscular monitor. The most common nerve monitored by this method. The most common nerve, we can use any nerve muscle junction. We have to use neuromuscular junction. We can use any nerve, any muscle junction. What is the most common nerve which is used? Answer is ulnar nerve. So, remember, in question if it is asked during GA, the most common nerve which is monitored, answer is ulnar nerve. Most common nerve monitored for neuromuscular monitoring, ulnar nerve. And where is this electrode put? Seeing where it is put, you can see it is medially put, ulnar nerve. So, answer is ulnar nerve. This is a very popular question of exam. So, keep it in mind. So, this is our neuromuscular monitoring. Next question. A 23-year-old primate, severe preeclampsia associated with thrombocytopenia, coagulopathy on magnesium sulfate therapy planned for emergency LSCS. So, full story. Neuromuscular monitoring with peripheral nerve stimulator was done to assess the neuromuscular blockade. The nerve most suitable for neuromuscular monitoring in this patient. Any patient, this is a story and they have asked in this patient, any patient, the most suitable nerve for neuromuscular monitoring? Ulnar nerve. So, remember, ulnar nerve is the most suitable nerve to be monitored. Why? Because it is easily accessible and it correlates best with the paralysis of intercostal muscle and the diaphragm. So, ulnar nerve is best nerve for neuromuscular monitoring. Okay, got it? So, ulnar nerve. Next question. Okay, now question on anesthesia machine. So, we have finished the question on monitoring. Some very important question which can be asked on monitoring. What are the mandatory monitors? We discussed 5 mandatory monitors. Then what are the desirable monitors? We discussed 2 desirable monitors, BIS and your neuromuscular monitoring, and rest all come under others monitor. Then this one monitor which is important from exam point of view is capnography, the different graph which we discussed and the condition in which the ETCO2 value would increase or decrease. Those are the important questions which can be asked on monitoring. One last thing I want to add in monitoring which can be asked, a bonus question type, right? What is the transesophageal echocardiography used for? Transesophageal echocardiography used for echocardiography. So, guys, I already have not written this monitor in mandatory or desirable. So, this is transesophageal echocardiography and this is a monitor which is used in perioperative period for cardiovascular monitoring, and this is the most sensitive, best perioperative cardiovascular monitor. So, remember, this is best perioperative cardiovascular monitor. Okay. So, this is best perioperative cardiovascular monitor and this is the best monitor to diagnose intraop air embolism also. So, this is most sensitive monitor to detect intraop air embolism, to detect intraop air embolism. So, remember, to detect intraop air embolism, this is the best monitor, transesophageal echocardiography. So, these are the 2 questions which are asked on transesophageal echocardiography. Got it? Okay. Now, next question on machine. So, all are true about oxygen flush valve except. So, oxygen flush valve, an important part of anesthesia machine. So, they have asked a question on flush valve. So, before talking about the oxygen flush valve, a very quick look to the anesthesia machine and what are the expected questions in your exam from anesthesia machine. So, I just talked about anesthesia machine, right? So, what is anesthesia machine? It is a device or a equipment which accept the gas from the source. So, what are the source? Gas cylinders and the gas pipeline. So, it accepts the gas from the source, then it reduces the pressure of the gas, mix the gas in the required concentration and deliver the gas to the patient through the common gas outlet of the machine continuously. So, continuous outflow of gas after starting in anesthesia machine. Continuous outflow of gas happens from anesthesia machine, right? Now, this machine has various parts and parts are divided according to the pressure, So, I just want to tell you that let's say this is anesthesia machine again. This is your cylinder. Now, cylinder has a pressure, let's say oxygen cylinder has a pressure 2200 psi. Okay. When the oxygen comes out of the cylinder, its pressure is reduced and now its pressure is 40 psi. So, from 2200 it became 40. So, till here before 2200, 40. Before passing from this pressure regulator, this was in high pressure system. So, now it is 40 psi and your pipeline meets at this after the first pressure regulator. So, it is an intermediate pressure system. Now, after this it passes again from the second pressure regulator. Again the pressure reduces to 10 psi which our lung can tolerate. So, now it is in low pressure system. So, from high pressure to intermediate pressure to low pressure. These are the three parts in which machine is divided. There is so we normally get gas coming out from the low pressure system at 10 psi. So, this is how we normally get. But there is a button in the machine, this is called flush valve. When we press this button bypasses the low pressure system and bring the gas from intermediate pressure system to the outlet. So, this button, emergency oxygen flush, comes under intermediate pressure system. It does not pass from low pressure system and it gives 35 to 75 liters per minute of oxygen. So, it can give 35 to 75 liter per minute of oxygen on per press at a pressure 45 psi, right? So, this is your emergency oxygen flush, okay, emergency oxygen flush. Delivery, all true about it except delivery of flow between 25 to 50 liters, what I just now said, between 35 to 75 liter per minute. So, this is incorrect. So, this is not true. So, this would be the answer. Barotrauma, if accidentally activated, our lung can tolerate 10 to 12 psi. Here it is giving pressure at 45 psi. So, there is a risk of barotrauma. Okay. Activation regardless of the master switch on off. So, this emergency oxygen flush is independent of the electrical supply, the master switch. We can press the flush even in the absence of electricity, it will operate. So, activation regardless of the master switch on and off. This is true. Okay. Then delivery of oxygen at a pressure 55 to 60. Yes, from 45 to 60 psi. This is the pressure at which the oxygen is delivered. So, this is also true. So, first one is incorrect. We need to remember 35 to 75 liter per minute of oxygen it will deliver. Okay. So, this is important. Next question. The best mean of identifying the content of cylinder. I told you machine has two sources. This is the cylinder and this is the pipeline. This is the pipeline. So, this is the two source of machine, cylinder and pipeline. Let us talk about this cylinder. Cylinder which keep the gas under pressure. This cylinder has three important parts. This is called body, right? The upper tapering end, this is called shoulder and the valve is attached to it. This is called valve. So, body, shoulder and valve. Okay. These are the parts of cylinder. Now, body and shoulder of the cylinder, they are color coded for every gas. So, there is a color coding of body and shoulder. Now, this is one way of identifying the content of the cylinder. Oxygen has a black body, white shoulder. Nitrous oxide, the whole cylinder is blue color. So, I can see it from outside. I know what is present inside it. Oxygen or nitrous oxide or carbon dioxide or air, whatever. But number of time, this is not adequate, right? Number of time, mistakes happen in spite of the color coding because not proper maintenance of these colors are done. So, what was done? A mandatory thing was passed that every time the cylinder will be refilled, there would be a label on the cylinder which has to be freshened. And that label is the best way to identify the content of cylinder. Remember, so label of the cylinder is the best way to identify the content of the cylinder. Color coding is one of the way, but not the best way. Pin index holes is another way which prevent the incorrect attachment of cylinder to machine, but it is not a way to identify the content of the cylinder. This prevents incorrect attachment of cylinder to machine, right? This prevents incorrect attachment of cylinder to machine. Okay. Markings on the cylinder shoulder, again no. So, answer is label. So, keep it in mind. Okay. Next point. A patient required oxygen in emergency room. All cylinders were empty. Now, what order would be given to the nursing orderly to bring the cylinder, right? So, oxygen cylinder. So, what order we should give to the nursing orderly to bring the oxygen cylinder? So, this is, let's say, the body and this is the shoulder of the oxygen cylinder. The body is black color, it is painted black color and shoulder is white color like zebra crossing, right? So, a cylinder with black body, white shoulder, this seems correct. Cylinder with white body, black shoulder, wrong, right? Cylinder with grey body, white shoulder. Now, grey body and black and white shoulder, right? A grey body and black and white shoulder and this is grey. This is for air. This is for air, right? A black body, grey shoulder, incorrect color coding. So, answer is a cylinder with black body, white shoulder. So, we need to have a crystal clear remembrance for the color coding of the cylinder. Okay. So, let us remember color coding of cylinders, right? Oxygen cylinder. As I said, black body, white shoulder. Black body, white shoulder. Then nitrous oxide. Everything of nitrous oxide is of blue color. So, it is the entire cylinder is blue color. Then your air. Air has grey body, black and white shoulder. So, it has grey body, black and white shoulder. Grey body, black and white shoulder. And carbon dioxide, the entire cylinder is grey color. So, this is the color coding of the cylinder which we need to remember. Okay? Okay, next question. Identify the image. So, this is a vaporizer. Guys, we talked about cylinder. The cylinder supplies gases like oxygen, nitrous oxide, air. But your potent inhalational anesthetics, they are liquid at room temperature and they need vaporizer to vaporize them and add to the oxygen and nitrous oxide, the carrier gas. So, vaporizer is a device which is used for storing and delivering our potent inhalational anesthetic agent. So, vaporizer is device used for storing and delivering potent inhalational anesthetic agent. Potent inhalational anesthetic agent, right? This is vaporizer of which agent? Now, vaporizer are color coded. So, remember few questions which we need to know about the vaporizer. As I told you, this is a device which is used for storing the inhalational. We put the inhalational in the liquid form. Now, vaporizer vaporize it, add it to the carrier gas and then together they come out of the the bypass channel of the vaporizer. Now, vaporizer is color coded. It is specific vaporizer is used for every agent, right? So, we have the inhalational agent, halothane, we have isoflurane, we have sevoflurane, we have desflurane, right? Now, desflurane is a unique inhalational agent. Its boiling point and vapor pressure is very different from other agents. So, it needs a special treatment. So, it needs a special vaporizer for itself. So, it needs a special vaporizing technique. So, special vaporizer is made for desflurane. One example is Tech 6 vaporizer. Okay. So, this is a special one, royal one. So, it has been given the color coding blue. Okay. The rest 3, they have similar vapor pressure and boiling point, but potency is different. So, and chemically they are different. So, we should not mix one agent with another. So, they also should have a specific vaporizer. Though vaporizing technique, vaporizer is similar, but vaporizer is agent specific. So, again we need a color coding to identify it is vaporizer of which agent. So, sevoflurane, what color coding? Now, you all remember sevoflurane is the best inhalational agent for children, and children like bright colors like yellow, sunshine color. So, sevo has yellow color code. Now, isoflurane has purple color vaporizer, purple color, right? And halothane is the danger color, danger, it's the danger agent, bad agent, danger agent. So, it has been given the red color. So, halothane red, iso purple, sevo yellow, and des royal one blue. So, here we have yellow and we have purple. So, this would be sevo and this would be iso. So, sevoflurane, isoflurane should be the answer. Okay. Halothane has red, right? So, remember halothane has red. N-fluorane has orange and desflurane has blue, and the vaporizer of desflurane also looks separate because it needs a special vaporizing technique. So, this is about the vaporizer. Next question. Which gas is respectively supplied by white, black and the yellow pipeline? So, I said there are 2 sources of gas, cylinder and the pipeline, right? Cylinder we have already discussed the color coding. Now, pipeline also follows the color coding. Pipeline also follows the color coding. And we have pipeline, gas pipeline plus vacuum system. 4 colored pipeline you will see. So, we have gas pipeline and vacuum system gas pipeline and vacuum system. As I said, 3 gas and 1 vacuum. So, what are the gases which are supplied through pipeline? Nitrous oxide, oxygen and air, and the vacuum for suctioning and all. Nitrous oxide, it has blue color code, oxygen white and air black, and the vacuum is yellow color. So, this is the color coding. And not only color coding is practiced, even the inlet of these pipeline going into the machine, those inlet has different diameters specific for every gas. So, that is something called DIS, that is diameter index safety system, right? Diameter index safety system or DIS. So, every pipeline, the terminal end is specific for that particular gas. So, this system prevents incorrect attachment of pipeline to machine. So, DIS is a system which prevents incorrect attachment of pipeline to anesthesia machine, right? So, this is a system which prevents incorrect attachment of pipeline to machine, we have to remember. So, this is another question which we have solved. So, let's come back on our question. White was of oxygen. Okay, black is of air, and yellow. Yellow is a vacuum. So, oxygen, air and vacuum. So, oxygen, air and vacuum. C would be the answer. Got it? So, this is the answer. Okay, next question. Okay guys, one more thing in machine which I think we should revise. I talked about the color coding of the cylinder. The cylinder which are attached to machine, they follow something called pin index. They follow something called pin index. What do I mean by this pin index? Pin index. Now, pin index is a system which prevent incorrect attachment of cylinder to anesthesia machine. This was the system which prevent incorrect attachment of pipeline to anesthesia machine. Pin index is a system which prevents incorrect attachment of pipeline to anesthesia machine, right? Pipeline to the anesthesia machine. Got my point? So, sorry, not pipeline, cylinder. For pipeline, what it is? Disc. Cylinder to anesthesia machine. Now, let's say this is the cylinder, this is the shoulder and this is the valve of the cylinder. On the valve of the cylinder, there is a opening called port, from which the gas will enter from cylinder into the machine. This goes into the nipple coming out from the anesthesia machine. Now, below port, there are two holes present specifically at fixed position to go into pins coming out below the nipple of the anesthesia machine. So, this would specifically go inside one another, the pins inside the pinholes. And this will be very specific for a particular gas. The arrangement will be very specific for a particular gas. So, this system will prevent incorrect attachment of cylinder to machine. If I try to attach another gas cylinder at a particular place, which is for some other gas, it will not fit. So, we need to know about the pin index. So, remember the pin index follow 15, 25, 35 and 16, 26 and 36 system. 15, 25, 35, 16, 26, 36. Now, 6 is like C. Gases starting from C, they come under 16, 26, 36 system. 16, 26, carbon dioxide. 36, cyclopropane. Okay. 15, 25, 35. Nitrous oxide, 3 atom, 2 nitrogen, 1 oxygen. It has 3, 5. Oxygen, 2 atom. 2, 5 and air is a mixture 1, 5. So, like this way, keep it in your mind, the pin index. Okay. So, this is all about anesthesia machine question which you need to cover. Now, let us talk about the questions of circuit. From machine, the gas will enter the circuit from the outlet of the machine. So, circuit, this is a question on circuit. Arrange the Mapleson circuit from spontaneous ventilation in an adult from best to worst. So, in circuit, 99% questions which are asked in exam are asked on Mapleson circuit. So, we need to know about what is this Mapleson circuit. Guys, first of all, what is circuit? Circuit is a two-way connection between machine and patient. Now, let's say this is your anesthesia machine. This is your patient. What is circuit? It's a two-way connection between patient and machine. It brings the inspiratory gas towards the patient. It removes the expiratory gas away from the patient. Now, Mapleson circuit is one such group of circuit which do the same thing. Okay. We have 6 Mapleson circuits. We have 6 Mapleson circuit. Mapleson A, B, C, D, E and F. We have Mapleson A, Mapleson B, Mapleson C, Mapleson D, Mapleson E and Mapleson F. These 6 circuits. And questions are asked on exam comparing these 6 circuits on 4-5 points. First, which of the following Mapleson circuits are adult circuit, which are pediatric circuit? Now, is there any other name of the Mapleson circuit? For what type of ventilation the circuit is good for? And how much we keep the flow from machine into the circuit to remove the carbon dioxide of the expiratory gas from the circuit. So, these are the 4 questions we have to answer. So, A to D, A, B, C, D, these 4 circuit, they are adult circuit, okay. E and F, pediatric circuit, these are pediatric circuit. Now Mapleson A, this is also called McGill circuit, So Mapleson A, which is also called McGill circuit, important. Its other name is McGill because it was designed by Dr. Ivan McGill. Okay, then this is the circuit of choice for a patient on spontaneous ventilation. So McGill circuit, this is circuit of choice for spontaneous ventilation, when the patient is breathing spontaneously, and we keep the fresh gas flow equal to the minute ventilation of patient for removal of carbon dioxide from this circuit. This is Mapleson A. B and C we are not using, so it is not in clinical use, we don't just have to remember. Mapleson D, this is also called Bain's circuit, and this is circuit of choice for controlled ventilation. This is circuit of choice for controlled ventilation, for IPPV, and we keep the fresh gas flow in this 1.8 times minute ventilation. So this 4 points we need to remember for adult. So in adult, which is the best circuit for spontaneous ventilation? The best circuit for spontaneous ventilation is Mapleson A, best for spontaneous. And which is the best circuit for controlled ventilation? The answer is Mapleson D, best for controlled ventilation. So if best and worst, how do we decide? By how much the fresh gas flow is required for that type of, in that type of circuit, for that ventilation. A needs least fresh gas flow for spontaneous ventilation, and D needs least fresh gas flow for controlled ventilation. That's why it is best, right, for respective type of ventilation. Now here in the questions, for spontaneous ventilation has been asked. So if we arrange A, B, C, D, the 4 adult circuit, from best to worst for spontaneous ventilation, A requires least fresh gas flow for spontaneous ventilation, it is best circuit, followed by D, followed by your B equal to C, right, B equal to C. So what should be the answer? Best is A, so either B or C. Second best is D, so C. So this would be the answer, okay. So this, how do we decide it? According to the fresh gas flow requirement. So this is decided according to fresh gas flow requirement, got it? Okay, next question. A 50 years old female who is in case of carcinoma cervix was posted for brachytherapy planned under TIVA with spontaneous ventilation, given through McGill circuit. So best circuit for spontaneous ventilation is McGill circuit, yes. So McGill circuit was attached. The fresh gas flow used in the patient is, so how much we should use the fresh gas flow? It should be equal to minute ventilation of the patient. So equal to minute ventilation, this is correct. Twice the minute ventilation wrong, 2.5 times wrong, and half the minute ventilation is incorrect. So answer is equal to minute ventilation. Got it? Okay. Next question. Which one of the following circuit doesn't have valve? Now guys, E and F, these are 2 pediatric circuits. So let us talk about Mapleson E and Mapleson F. These 2 are pediatric circuit, right? And in children, we don't want high pressure and high flow to be generated. So what was done? A very simple circuit was designed, an inverted T-shaped circuit, in which there was no expiratory valve for resistance and no bag for positive pressure ventilation. Now this is bagless valveless circuit, and this was called Mapleson E, or the other name of Mapleson E is IR's TPs, okay. So this one end is attached to the patient, other end to the atmosphere, and this end the fresh gas enter, okay, fresh gas enter. So this is Mapleson E. It has no bag and no expiratory valve, vagus valvulus. Now this circuit was not very useful. So the same circuit was taken by a person called Jackson Rees. And what Jackson Rees did, he attached a bag into it, bag. Now this became Mapleson F. So Mapleson F is the best circuit in pediatric for any type of ventilation. This is the only pediatric Mapleson circuit which we are using. So Mapleson F is best pediatric circuit, which we are using. Okay, so Mapleson F is the best pediatric circuit, or we call it Jackson-Rees circuit. So question is, which one of the circuit does not have valve? So answer is Mapleson E, or we call it IR's TPs. Okay, so Mapleson E or IR's TPs is bagless. This is bagless and valvulus, and also useless. And this was made useful by adding a bag, an open bag which was still open to atmosphere, so that pressure inside the circuit does not increase. So we can use it in pediatric, and this was Mapleson F or Jackson-Rees circuit. Remember, Mapleson F or Jackson-Rees circuit. Okay, next question. Okay, now question on fluids, very important, fluids. So let us very quickly revise little thing about fluids. What is fluid? I mean, you must be knowing fluid is divided into two broad divisions, crystalloid and colloids. Okay, crystalloid and colloids. Now, before I tell you about crystalloid and about colloids, just very quickly, a quick revision of total body water. So total body water is 60% of total body weight, and of this 60%, 40% is present in the intracellular fluid compartment and 20% is in your extracellular fluid compartment. And in extracellular fluid compartment also, it is divided into intravascular and interstitial fluid space. Only 5% is intravascular, 15% is interstitial. So this 5% is our target fluid which we need to fill to maintain the perfusion of the body, to maintain the blood pressure. So this 5% is our target fluid. Okay. So fluid is divided into two types, crystalloid and colloid. What is crystalloid? Crystalloid is aqueous solution of low molecular weight electrolyte. Crystalloid is aqueous solution of low molecular weight electrolyte. Low molecular weight electrolyte. Okay. What is colloid? It is aqueous solution of high molecular weight substance. High molecular weight substance. Okay. Crystalloid, low molecular weight electrolytes. So it is like sodium, chloride, potassium, and high molecular weight substance like starch, gel fusion, etc. Right? So this is the difference. Now crystalloid, when you give, it does not remain in intravascular fluid space. What it does, it receives an equilibrium in total extracellular fluid space. So only 1/5 of the crystalloid remains, 1/3 of the crystalloid remains in the intravascular space, 2/3 goes into interstitial space because it is divided into 1:3 ratio. 5% intravascular, 15% interstitial. So similarly, 1/3 remains in the intravascular, 2/3 goes into interstitial. So when I am using crystalloid as a replacement fluid for the blood loss, we use it in 3:1 ratio. Colloid remains in the intravascular space only. So we use it in 1:1 ratio. Now crystalloid is of various type. We have isotonic, we have hypotonic, and we have hypertonic. Right? This is according to the difference in serum osmolality of the crystalloid. Difference from the serum osmolality. Isotonic equal to the serum osmolality, hypo less than serum osmolality hyper more than serum osmolality. Example, isotonic crystalloid is the crystalloid which we use routinely in perioperative period. So, isotonic crystalloid like normal saline, right, the balanced saline solution or Ringer's lactate, these are the routine isotonic crystalloid which we use. So, any question asked, what is the fluid which we use in perioperative period or which we use in surgical patient, which was asked somehow few days in few of the exam, which is the fluid we use in surgical patient? Always isotonic crystalloid, balanced salt solution like normal saline, Ringer's lactate, these comes under balanced salt solution. Okay, so isotonic crystalloid is what we are using. Okay, hypotonic 5% dextrose, not a useful fluid because dextrose gets metabolized and then it becomes free water, achieving an equilibrium in total body fluid space. Hypertonic, 3% normal saline, 6% normal saline, they are used for treatment of hyponatremia, etc. Correct? Colloid, two type. One is your one colloid is your natural, that is your blood and blood product. Synthetic colloid. So, it is of two type. Synthetic chloride are prepared in balanced salt solution. So, colloid is always isotonic. Colloids are always isotonic. So, this is little bit knowledge of fluid which we need to know for solving the question. Which crystalloid has osmolality nearest to the serum osmolality? Okay, isotonic crystalloid nearest to the serum osmolality. In this we have normal saline, Ringer's lactate. Now, Ringer's lactate serum osmolality is nearest to the serum osmolality. Okay. So, normal saline, Ringer's lactate. If we discuss their ionic composition, now sodium, potassium, chloride, osmolality, the lactate or acetate, whatever it has. Normal saline, it has 154 milliequivalent sodium and 154 milliequivalent chloride, right? Ringer's lactate, 131 milliequivalent sodium, 4 milliequivalent potassium and 111 milliequivalent chloride. Osmolality of normal saline is 303 milliosmol per liter. Ringer's lactate, it is 270, and lactate present in Ringer's lactate is 25 milliequivalents. Okay. Normal serum osmolality is near about 275 to 285. So, osmolality of Ringer's lactate is nearest to the serum osmolality. So, answer is Ringer's lactate, right? Okay. 5% dextrose is hypotonic. DNS, the same osmolality as normal saline. DNS is dextrose normal saline. Okay? Okay. Next. Which of the following is not useful fluid for resuscitation in a cardiac arrest patient? So, normal saline, Ringer's lactate, 5% dextrose, whole blood. So, fluid used for resuscitation. Why do we give fluid for resuscitation? To increase the blood pressure of the patient, Let us say this is the intravascular space, this is interstitial space and this is intracellular space. This is intracellular, this is extracellular, in which this is interstitial and this is intravascular. Now, intravascular and interstitial space separated by the membrane of the blood vessel, and extra and intracellular is separated by the cell membrane. Now, this cell membrane is basically impermeable to most of the electrolytes, right? It is only permeable to water, right? And this blood vessel, this is permeable to low molecular weight electrolyte, but impermeable to high molecular weight substance. Okay. So, when we give fluid for resuscitation, we need to maintain the blood pressure of the patient. So, we need to maintain the intravascular volume. So, we would like to keep the fluid in the intravascular fluid space. If the fluid crosses the interstitial and intra cell membrane, then that fluid will not remain in the intravascular fluid space, right? So, resuscitative fluid should remain in the intravascular space. So, colloid would be a very good resuscitative fluid, Because colloid remains in the intervascular space. It is made up of high molecular weight substance. Then, so colloid, we have blood and the artificial colloids, both are good. Then crystalloid. Now, crystalloid divide in 1/3 to 2/3 between intravascular and interstitial, but does not go in intracellular fluid space. So, again, if we give in 3:1 ratio, it will remain in intravascular space. Okay, 5% dextrose. Dextrose gets metabolized and then it becomes free water, achieving an equilibrium in total body fluid space. So, maximum goes into intracellular space, minimum remains in intravascular space. So, if you give gallons of 5% dextrose, then also the blood pressure of the patient will not increase. So, 5% dextrose is not a resuscitative fluid. We use normal saline or Ringer's lactate initially. We use whole blood, but we never use 5% dextrose. Got it? So, keep it in mind. So, this is important. Okay, next question. There is an image of a green cannula. What is the gauge? So, how do you give your fluids? How do we give fluids, right, in intravascular space? Two ways. We can give through peripheral cannula or we can give through central line, right? Peripheral or the central line, right? Now, peripheral IV cannula, we have color coded, and for central we put the central venous catheter, okay? And for peripheral we put, for peripheral fluid infusion we put the peripheral cannulas. So, here peripheral cannulas we have, they are color coded, okay? They are color coded. So, we need to remember their color coding and few things about the cannulas. So, very important, the color coding of the cannulas. We have, starting from thickest to thinnest, I am coming, 14 gauge, 16 gauge, then 20 gauge, 18 gauge, your, sorry, 16, after 16 I should have written 18 gauge, 20 gauge, 22 gauge, 24 gauge and 26 gauge, okay? Thickest to thinnest. 14 gauge, this has orange color coding, and 16 gauge, this has grey, and both these cannula, they are thick cannulas and we use it in trauma patient for fluid resuscitation, because they can be used to transfuse the fluid very quickly. So, they are the, we use in trauma patient or cardiac patient. 18 and 20 gauge are the two important cannula, the sizes which we are using routinely in perioperative period. So, these two are what we are using in perioperative period in adult patient, okay? 18 gauge and 20 gauge. 18 gauge is your green cannula and 20 gauge is your pink cannula. Green cannula, that is 18 gauge. The flow rate, how fast the fluid can go through it, 90 to 110 ml per minute. Pink, it is 55 to 60 ml per minute, okay? 22 gauge, that is your blue cannula, and 24 gauge, that is your yellow cannula. We use it in pediatric. This is used in small children. And 26 gauge, which is purple cannula, this is used in very, let's say, neonates or premature child or old, very old person who have very thready veins, okay? So, we need to remember the cannula. So, green cannula, what is the gauge of green cannula? The green cannula is 18 gauge, got it? So, answer is 18 gauge, okay? Okay, next question. Very important. A 25 years old female presented to emergency with palpitation and dizziness, some symptoms. ECG was done and was diagnosed by seeing the ECG supraventricular tachycardia. Her blood pressure was 60/40. First line of management for this patient. What is the first line of management? So, this is a case of symptomatic tachyarrhythmia. So, first I will tell you the answer and then I will discuss. Symptomatic tachyarrhythmia. I am not writing supraventricular tachyarrhythmia. I'm simply writing symptomatic tachyarrhythmia because irrespective it was SVT or atrial flutter or atrial fibrillation, if the presentation was the same, what is described in the question, the management would have been same. So, all symptomatic tachyarrhythmia, the management is same. Answer is cardioversion. Answer has to be cardioversion. If the tachyarrhythmias are asymptomatic, then only there is some specific management. If it is symptomatic, management is same. Answer is cardioversion. Okay. So, let us discuss little bit about tachyarrhythmia. Tachyarrhythmia. I am not talking about tachycardia. I am talking about tachyarrhythmia. And let me add tachycardia also. So, what is tachycardia? Tachycardia is just heart rate more than 100, but it is following PQRST pattern. So, PQRST pattern is being followed, but the heart rate is more than 100, but PQRST pattern is being followed. Tachyarrhythmia, heart rate very high, more than 140, 50, and PQRST pattern not followed, right everyone? Now, in tachyarrhythmia, again we divide it into according to the QRS complex. It is divided according to QRS complex. Whether it is a narrow QRS complex means less than 0.12 milliseconds the size of the QRS complex, less than the 4 small box, and broad QRS complex, that is more than 0.12 milliseconds. Narrow QRS complex, we have 3 important tachyarrhythmia. The paroxysmal supraventricular tachyarrhythmia, that is PSVT, atrial flutter and atrial fibrillation. Okay, these are the 3 important. And broad QRS, you have ventricular tachyarrhythmia, Okay. Now, how do we treat tachyarrhythmia? The treatment of tachyarrhythmia depends upon one very important thing, that when tachyarrhythmia is there, patient is symptomatic or asymptomatic. So, when someone presents with tachyarrhythmia, we see whether the symptoms are present or not. So, what symptoms? Symptoms of poor perfusion, like patient is in shock, patient is having syncope, patient is having palpitation, right, low blood pressure, acute chest discomfort, patient is complaining, going into acute heart failure. So, these are the symptoms if this is coming, right. Then in tachyarrhythmia, irrespective QRS complex, broad, narrow, whatever, the management is cardioversion. We immediately give the patient a 50 to 100 joules synchronized shock. Cardioversion is synchronized shock. It synchronizes in the non-refractory period of the heart at the peak of the QRS complex, and it can convert the rhythm into sinus rhythm. So, we do cardioversion. So, for symptomatic tachyarrhythmia, as in our patient, we do cardioversion. Keep it in mind. Now, coming on the next question. A patient presents with palpitation, feeling uneasy. His hemodynamic status is normal. Following is the image of the ECG finding, which is the treatment of choice. So, this is again, if you see this, we can see that the heart rate is very high, more than 150 per minute, right? And we are not able to see the P. So, this is PSVT, that is paroxysmal supraventricular tachyarrhythmia, unable to see the P wave. So, this is PSVT and patient blood pressure is normal. So, let us say this is asymptomatic tachyarrhythmia. In this, what we will do? If it is asymptomatic and narrow and and it is PSVT, paroxysmal supraventricular tachyarrhythmia, the first line of management is that what we do, we do vagal maneuver. We do vagal maneuver while we are preparing the drugs. The second thing, we do vagal maneuver. Sorry guys. Till we do the vagal maneuver. The second thing, we would give a very important drug, the treatment of choice in the PSVT, adenosine. Adenosine. So we give 6 milligram adenosine, followed it with 12 milligram, followed it with 18 milligram if we are not getting the effect. So adenosine is treatment of choice. So answer would be IV adenosine. Immediate defibrillation, this is done in cardiac arrest. Defibrillation is done in cardiac arrest, right? Synchronized cardioversion is done in symptomatic tachyarrhythmia. IV ibutylide is as antiarrhythmic, and this is given in ventricular tachyarrhythmia, asymptomatic ventricular tachyarrhythmia. This is supraventricular asymptomatic tachyarrhythmia. So according to the type of tachyarrhythmia, we will manage. In PSVT, it is adenosine, which is the drug of choice. So remember this. These two questions are very important on tachyarrhythmia. If the symptoms are there, I mean blood pressure is becoming low, immediately cardioversion. If the blood pressure is normal and it is PSVT, then we go for adenosine. If it is flutter or fibrillation, we simply try to decrease the ventricle rate by giving a calcium channel blocker or beta blocker. Okay, so this is how we manage tachyarrhythmia. Okay, next question. A 45 years old male who was case of polytrauma from road traffic accident came to the casualty. On examination, the blood pressure was not recordable, carotid pulse was not felt, and immediately cardiopulmonary resuscitation was started. So patient was in cardiac arrest. According to the ACLS guideline, the pulse is checked for the return of pulse during cardiopulmonary resuscitation in this patient. So they are asking the pulse to be checked. So which pulse we check in an adult patient for confirming the cardiac arrest and during management of cardiac arrest? So in adult, this is a 45-year-old male adult, the only pulse is carotid pulse which is checked. Femoral is checked in pediatric. So pediatric, what does pediatric mean? Pediatric means more than 1 year to puberty. What does adult mean? Puberty onwards, okay? And brachial is checked in infant less than 1 year, okay? So remember, 3 important pulse: carotid or femoral or brachial. Carotid always in adult, carotid or femoral in pediatric, and brachial in infant. So in cardiac arrest management, these are the important pulse which we need to check. Now in cardiac arrest management in adult, the ventilation, so the compression ventilation ratio is always 30:2, irrespective of whether it is a single rescuer or multiple rescuer. In pediatric and infant, the compression ventilation ratio is 3:2 if the rescuer is single and more than 1 if the rescuer is 15:2. More than 1 if the rescuer is 15:2. Okay. So in pediatric and infant, 15:2 compression ventilation if the rescuer is more than 1, and less and 1 only 30:2. Keep it in mind. Then depth of chest compression. Depth of chest compression. Depth of chest compression in adult is always 5 centimeter. We have to keep it at least 5 centimeter. Pediatric about 5 centimeter and infant about 4 centimeter. Okay, and in all three, the rate of chest compression is always 100 to 120 compression per minute. So this is important differences which we need to keep in mind. Okay. Okay, next question. A 5-year-old child, known case of congenital heart disease, suddenly becomes unresponsive in Sharping Mall. Unresponsive. Not guideline which is included in BLS to be started in this child. So what is wrong in managing BLS of this child. So child is a cyanotic heart disease patient, becomes unresponsive. So we have to do BLS. And what is wrong? It has been asked. Compression ventilation 15:2 when more than one rescuer is present in infant. Now, for infant, this is a correct thing. For child and infant, 15:2 when more than one rescuer. So this is correct. Brachial pulse check every 2 minutes. This is a 5-year-old child. And in 5 pediatric patient, either carotid or femoral, not brachial. So this is incorrect. So this should be the answer, right? The ratio of compression ventilation to rescue breath 30:2 for a single rescuer. This is correct. The depth of compression should be more than or equal to 1/3 of the anteroposterior diameter of the chest, which comes out to be about 5 centimeters. This is also correct. So which is incorrect? Brachial pulse to be checked. This is incorrect. So we have to keep it in mind. Okay. So this is important. Okay. Now very important questions on oxygen therapy. Let us talk about oxygen therapy. What is oxygen therapy? Oxygen therapy is giving oxygen at more than room air oxygen concentration. So oxygen therapy is giving oxygen at more than room air oxygen concentration. More than room air oxygen concentration. So when we are giving oxygen at more than room air oxygen concentration, that is what is called oxygen therapy. Got it? That is what is called oxygen therapy. Now there are two types of device which we use for oxygen therapy. Low flow variable FiO2 delivering device and high flow fixed FiO2. High flow fixed FiO2 delivering device. Low flow variable FiO2 delivering device. Low flow variable FiO2 delivering device. Remember this. These devices, whatever device we will discuss, in this the flow is less than 15 liter per minute. So maximum flow is less than 15 liter, less than equal to 15 liter per minute. So that's why it is called low flow. Variable FiO2, in this the FiO2, the fractional inspirated oxygen concentration, the oxygen concentration which we are giving is variable, varies according to the breathing pattern of patient. So if same nasal cannula is attached in you or in me, depending upon our breathing pattern, it will vary in its oxygen delivery concentration. Maybe I have a normal breathing pattern, it will deliver a high FiO2 of let's say 0.4, 40%. You have a very shallow breathing, it will deliver only 0.3 FiO2, 30% of oxygen. So it is variable. So FiO2 is variable, depends on breathing pattern of the patient, depends on breathing pattern. Now high flow fixed FiO2, very high flow up to 60 liter per minute, right? And FiO2 is fixed. You cannot vary the FiO2. FiO2 is fixed. You cannot vary the FiO2 in high flow fixed FiO2 delivering device. Got my point? So keep this in mind. Now what are the devices which comes in your low flow variable FiO2 delivering device? 3 devices you remember. Number 1, normal conventional nasal cannula, Number 2, face mask, and number 3, your NRM, non-rebreathing mask. So these 3 important devices you have to remember. High flow, HFNC, high flow nasal cannula, and a very important device is your Venturi mask, very popularly asked in your exam, Venturi mask. So these 2 are high flow fixed FiO2 delivering device. Okay, so now let us discuss the next question, the question which we had to discuss. Okay, maximum FiO2 which can be given through nasal oxygen catheter. So nasal cannula which comes under low flow variable FiO2 delivering device. So let us talk about this nasal cannula. Okay, nasal cannula, what is the flow we give through nasal cannula? Now there are two cannulas. We put in both the nares and it is attached to the oxygen flow meter to give oxygen. How much flow we give? We can start from 1 liter per minute to we can go till 6 liter per minute, right? 1 liter per minute to 6 liter per minute. Per 1 liter of oxygen we are giving through the oxygen piping, 4% oxygen concentration increases above room air, right? Above room air. So 4% oxygen concentration increases above room air. So if I am giving if I am giving my patient oxygen at a 2 liter per minute, so 2 into 4, 4 into 2 is 8% plus 21% the room air oxygen concentration. So patient is getting 29% oxygen, okay. So per 1 liter, right, per 1 liter, 4% increases. So at 2 liter, 8% will increase. 3 liter, 12% over room air will be increased. So what is the range it will give? At 1 liter, it will give 25% and at maximum 6 liter, it will give 45%, right. So what is the maximum FiO2 delivered by nasal cannula? This 45%. So this would be the answer. 0.45 means 44 means 0.44 means 44%. Okay. So this is how we have to calculate. So maximum it will deliver would be 45%. Remember, nasal cannula 1 liter to 6 liter, it gives oxygen between 25 to 45%. Got it? Okay, next question. A patient with acute stroke presented to emergency with tongue fall. A oropharyngeal airway was to be introduced to maintain the patency of the airway. How should we measure the right size of oropharyngeal airway? Guys, now this is a question on basic airway adjunct. Basic airway device. Now basic airway device is used to, these are the devices which we use to open the airway. So these devices are used to open airway, obstruction, to relieve obstruction. Now two very important device comes into it, oropharyngeal and nasopharyngeal. Oropharyngeal, that is OPA, and nasopharyngeal. Nasopharyngeal, that is NPA. Oropharyngeal, as it says, we introduce from oral cavity, it goes into the oropharynx, lifts the tongue. Nasopharyngeal, nasal cavity to the pharynx, creates a conduit for the air to pass. Now, there are few things we need to know. Oropharyngeal airway is the best airway to open the airway in unconscious patient. We should avoid it in conscious patient because it can generate airway reflexes, spasm, etc. can happen. Nasopharyngeal airway should only be used in, it should be used in conscious patient where we cannot use oropharyngeal airway. Now, in unconscious patient, oropharyngeal airway is good enough. It lifts the tongue. How do we insert it? It comes in assorted size. To insert it, first we measure the size. We take the oropharyngeal airway. It is a curved device. We keep it on the angle of mouth to angle of mandible. This should be the length of the oropharyngeal airway for that particular person, right? So we measure from angle of mouth to angle of mandible. Angle of mouth to angle of mandible. Nasopharyngeal airway from tip of nose to ear lobule. Tip of nose to ear lobule. Okay. So this is how we measure the size of airway. Okay. So patient was in stroke, presented emergency with tongue fall. OPA was to be introduced to maintain the patency of airway. How do we measure the right size? So we measure the right size by measuring from angle of mouth to angle of mandible. So measure the length from angle of mouth to angle of mandible. This is the correct answer. This is the correct answer. Okay. Tip of nose to ear lobule. This is for nasopharyngeal airway. Got it? So this is the right answer. Okay. Next question. Identify the type of ET tube in the picture. So this ET tube we have been asked to identify. Guys, endotracheal tube, endotracheal tube, ET tube, endotracheal tube. Now this is introduced in the glottic opening and it remains in the trachea, it remains in the trachea. We inflate the cuff, it creates a seal in the trachea. So this is your endotracheal tube, and this endotracheal tube is used for various purposes. We use it for mechanical ventilation, the most important work. And whenever we use the endotracheal tube for mechanical ventilation, it should be cuffed tube. It should be cuffed ET tube, because this cuff will create a seal for the ventilation to happen. Okay. Now, standard ET tube we use in most of the patient, but there are some special ET tube which we need to know. Now, one very special ET tube is this one. If you see this ET tube, on the inner circumference, metallic wire has been reinforced. So this make this tube clink resistant. So this tube is also called flexometallic or armored or reinforced tube. Reinforced tube. So flexometallic, armored or reinforced tube, right? Laser tube is a special tube we use for laser surgery, right? RAE tube. RAE tube is called preformed tube. Preformed tube. This is a bent tube. We use it for cleft lip palate surgery. Cleft lip palate surgery. And double lumen tube, which has two lumens, a bronchial and a tracheal lumen. This is used for thoracic surgery. Thoracic surgery. So these are the four important tubes you keep in mind. This one is your flexometallic or armored or reinforced tube. Got it? Okay. Next question. A 42 years old patient was brought to emergency after RTA. On examination, signs of airway obstruction was observed. What should be the immediate measure taken by the resident on duty to relieve the airway obstruction? So, patient is an RTA patient with airway obstruction. And now it has been asked what maneuver we do to relieve the airway obstruction. In 2 questions back, we discussed device we use to prevent airway obstruction. So, what is the device which we use to prevent airway obstruction? Either oropharyngeal, nasopharyngeal airway. Before inserting these devices, there are some maneuvers also which we can do to open the obstructed airway. Now, what is that maneuver to open the obstructed airway? Now, there are 2 maneuvers which we can do. So, airway opening maneuvers, 2 maneuvers. Number 1, head tilt chin lift, head tilt chin lift. So, head tilt chin lift. This is the first maneuver. Okay. Number 2, jaw thrust, right? Jaw thrust. So, this is the second maneuver. These are the 2 maneuvers which we do, and we need to know few important things about these 2 maneuvers. Well, head tilt chin lift. I want to show you the image of head tilt chin lift. In head tilt chin lift, head is tilted backward, chin is lifted upward. This lifts the tongue. There is movement of head and neck joint. So, in trauma patient, we try to avoid it. So, this is the maneuver of choice in non-trauma patient, head tilt chin lift. Jaw thrust, we keep the head and neck in neutral position. We just protrude the mandible, lift the mandible. This is the maneuver of choice in trauma patient. Which is the better maneuver? Head tilt chin lift is a better maneuver. Right everyone? Head tilt chin lift is a better maneuver. Okay. So, 42-year-old patient posted for emergency, brought out for road traffic after road traffic accident. On examination, signs of airway obstruction was observed. What should be the immediate measure taken by the resident on duty to relieve the obstruction? So, this is a trauma patient. So, we would go for jaw thrust. So, jaw thrust should be the answer. Okay. Now, next question. A 42-year-old patient in post-anesthesia care unit after reversal from GA with airway obstruction. What should be the immediate maneuver taken by the resident on the duty to relieve airway obstruction? So, this is Non-trauma. Non-trauma with airway obstruction. We would go for head tilt, chin lift. Got it? Trauma, we would go for jaw thrust. Non-trauma, we would go for head tilt, chin lift. So, this is the clinical question which is asked. The image-based question, they ask, they show the image and they ask to recognize. So, head tilt, chin lift. Head is tilted backward, chin is lifted forward. Jaw thrust, both the hands are doing the same work. So, keep this image in mind. So, image-based question for the image-based question. Okay? Okay, next question. In a mechanically ventilated patient, tracheostomy was done. Which would be the best tracheostomy tube to be used? Okay guys, I already told you, ventilation is one of the primary indication for putting the tube. And for ventilation to happen, we have to put the cuffed tube. So whether we use tracheostomy for ventilation or ET tube, we have to use the cuff one. So cuffed tracheostomy tube is what we will use. Okay. Uncuffed tube, not much of clinical use. Uncuffed is mostly used during decannulation. Decannulation, when we are removing the tracheostomy tube. Metallic tracheostomy tube is used when we are promoting and when we use tracheostomy tube for a long time. And fenestrated tracheostomy tube is used when we are promoting vocalization in the patient. Right? Mechanical ventilation, cuffed tracheostomy tube. Keep in mind. Okay? Okay, next. A young patient posted for congenital cataract surgery under general anesthesia. To secure the supraglottic airway device was used. All are the benefits of supraglottic airway device over endotracheal tube except. So guys, we talked about the airway device. I just now told you airway device, the advanced airway device. Now advanced airway device like endotracheal tube, supraglottic airway device, this is your glottic opening. This is your trachea. This is your right and left bronchus. When we put the tube goes in the trachea, we inflate the cuff, right? And when we put the supraglottic airway device, it remains above the glottic opening, right? Okay. Now this supraglottic airway device, this also forms a seal over the glottic opening, but the seal is not strong enough to prevent aspiration. So major drawback of the supraglottic airway device is it cannot prevent aspiration. Endotracheal tube very well prevents aspiration. So that is the major demerit of supraglottic airway device over endotracheal tube. Okay. So here the question is asked. The patient was put supraglottic airway device. All are benefit of supraglottic airway device over ET tube except. It is less invasive. Yes, it remains above the glottic opening. Less invasive. It causes less hemodynamic alteration. Yes, because it does not touch the tracheal wall. It prevents aspiration. Now, this is the major issue. Aspiration cannot be prevented 100% by supraglottic airway device. So, this would be the answer. Best device to prevent aspiration is endotracheal tube. So, this is the best device to prevent aspiration. It requires less time for insertion. Yes. For ET tube, we need to do laryngoscopy, then put the tube. For supraglottic airway device, open the mouth, push it. Goes at the right place. Very easy and fast to insert. Got my point? Okay. So, this is supraglottic airway device. Okay. Next question. Now, recognize this device. Question is, the diagram of correctly positioned ProSeal. So, this device is ProSeal. It has been given. ProSeal LMA is provided below. Correctly positioned. Above, what is the site of the arrow? So, this is the arrow here, marked area where it will be positioned. So, when I put this device, this portion, where would it sit in the oropharynx? Now, this is the tip of the mask of the laryngeal mask airway, and this tip goes and sit in hypopharynx on esophagus, just above esophagus, right? Now, this is a ProSeal. This is drain tube of the ProSeal through which we can put the Ryle's tube in the esophagus of the patient. And this is the airway tube through which we can ventilate. So, remember the LMA, it has a mask and it has an airway tube. This is a classical LMA, classical. and it had an opening in its ventral part for ventilation, and this sat on the glottic opening. The tip used to sit on esophagus. Now this LMA was improved into the second generation LMA, ProSeal. Now ProSeal has an airway tube and it had a gastric tube which ended on the tip with an opening on the tip. This tip always sits on over esophagus. There is an opening for the ventilation through airway also, but the tip, there is an opening which sits on esophagus. So always the LMA, the tip sits above esophagus. So tip always sits above esophagus. Keep it in mind. Got it? Okay. Next question. Again, a question on oxygen delivering device. Very important topic. Very important topic. Okay. A 34-year-old male admitted in ICU with history of high-grade fever, cough, myalgia, loss of sensation of smell for past 1 week. His blood pressure is 100/60, pulse rate 110 per minute, saturation 90%, respiratory rate 25 per minute, temperature 102. His chest X-ray showed peripheral ground glass opacity. He is treated with 15 liters per minute of oxygen through NRM. What is the maximum FiO2 delivered by NRM? Okay, I mean, no need to read such a big question. The question is one line. Non-rebreathing mask deliver how much FiO2? So, non-rebreathing mask, another low flow device less than equal to 15 liters per minute of flow, and variable FiO2 it will deliver, variable FiO2. So, what is the maximum FiO2 delivered by non-rebreathing mask? This device, this is a mask with a reservoir bag with a one-way valve between the mask and the reservoir bag. This gives a very high FiO2 of 0.7 to 0.9. So, remember, NRM, non-rebreathing mask, can give a very high FiO2. It can give maximum FiO2 among low flow devices. Okay, very high FiO2. Okay. What is the maximum flow rate of conventional oxygen therapy? Again, oxygen therapy. Guys, low flow device for the oxygen therapy, we call it conventional oxygen therapy. Conventional oxygen therapy. And routinely I am telling you, the maximum flow rate which we can give through conventional oxygen therapy, low flow device, is 15 liters per minute. So, maximum flow rate by conventional oxygen therapy, 15 liters per minute, right? This should be the answer. Okay, next. Maximum oxygen concentration delivered by which of the following device? Venturi mask, Hudson mask, nasal cannula, non-rebreathing mask. Now, Venturi mask is a high flow device, but the major demerit, FiO2 maximum it can deliver 0.6, that is 60% oxygen. Hudson mask is a normal mask, and it can deliver 60% oxygen concentration. Nasal cannula, 45% oxygen concentration maximum it can give. Non-rebreathing mask, from 0.7 to 0.9, 70 to 90%. So, this can deliver the maximum FiO2. But this is patient dependent variable device, right? Variable FiO2 delivering device. Remember that. This delivers maximum FiO2 60%, but independent of the patient. I am just telling you the difference. But in this question, maximum oxygen concentration has been asked. So, answer has to be NRM, non-rebreathing mask. Alright. So, this is an important question. Okay, next question. Identify the instrument given below. Very important question. This is your favorite question of exam. This device is favorite device. This is a Venturi barrel, which is part of Venturi mask. So, what is this? This is a Venturi mask. Okay, guys, normal mask, the oxygen opens in the mask itself. But in Venturi mask, there is a Venturi barrel attached to which the oxygen is attached. And with a high flow we give oxygen, it passes through this Venturi barrel and the very high flow total gas is delivered to the patient. So, this is a Venturi barrel. Got my point? Venturi barrel. Okay? Okay. There is a case of conventional mask, highest FiO2 produced by which of the following? Again the same question. highest FiO2 which device will give? Venturi mask 0.6, rebreathing mask 0.7 to 0.9, Hudson 0.6, nasal cannula 0.45. Answer is rebreathing mask. Again I am repeating because with different language the same question has been asked. If they ask maximum FiO2, you have to answer rebreathing mask, NRM. Rebreathing or NRM, non-rebreathing mask. Okay, the difference between rebreathing and non-rebreathing is just a difference of one-way or a two-way valve between mask and the reservoir bag. Got it? Okay. Next question. A 1-year-old child, a case of dislocation of hip, inhalational induction with 8% sevoflurane was done, intubated with 3.5 mm ET tube. The ideal type of ET tube used in patient. So, it's a child in less than 6 to 7 years. The cricoid is the narrowest part of the airway. So, we use uncuffed tube. So, uncuffed tube would be the answer. So, uncuffed tube does not have a cuff, uniform diameter. So, less than 6 to 7 years, we use uncuffed tube. Flexometallic tube we use in neurosurgery and all because it is kink resistant. RAE tube we use in cleft lip palate surgery, cleft lip palate surgery. Double lumen tube we use in thoracic surgery, Got it? So, remember uncuffed tube. Okay, next. So, now let us discuss some of the questions on drugs. Which of the following anesthetic agent has highest MAC? So, we need to have little concept of MAC. What is MAC? MAC is minimum alveolar concentration. Minimum alveolar concentration. And we need to remember that MAC is inversely proportional to the potency. Higher the potency, lower is the MAC. Lower the MAC, higher would be the potency. So, remember, MAC tell us about the potency of the agent. So, to remember the potency of the agent, I told you to remember the sequence in which the agent came in clinical practice in a lot of my lectures. So, halothane came first in clinical practice, then iso, then sevo and then desflurane. And their MAC increases in the same sequence. So, their potency decreases in the same sequence. And the carrier gas which are less potent. Nitrous oxide has highest MAC and this makes it least potent. Then xenon, a new carrier gas, it has a lesser MAC than nitrous oxide but much higher than the potent agent. So, it is less potent than the potent agent but more potent than nitrous oxide. And overall the most potent agent is methoxyflurane. It has the highest MAC. So, if I compare the potency, methoxy is highest potent, then halothane, then iso, then sevo, then des, then xenon and then nitrous oxide. So, this sequence is very important for your exam point of view. Okay. So, highest MAC which agent has? Nitrous oxide, which makes nitrous oxide least potent. So, nitrous oxide is least potent. Okay. So, if I compare the MAC, most potent agent overall is methoxyflurane, followed by halothane, followed by iso, followed by sevo, followed by des and followed by nitrous oxide. In middle we have xenon also. Okay. So, remember this, nitrous oxide is least potent. Next question. A special vaporizer specially designed for inhalational with low boiling point and high vapor pressure, which is the agent. Now, as we discussed previously in all question also about the vaporizer. Now, vaporizer as I told is a device which is used for storing the inhalational and for delivery of inhalational. Most of the inhalational, they have the same boiling point and they have the same vapor pressure. Only desflurane, it has a low boiling point. It boils at room temperature 23 degrees Celsius and it has a very high vapor pressure 667. So, it needs a special vaporizing technique. So, desflurane requires a special vaporizer. One example of special vaporizer is Tech 6 vaporizer. Okay? Okay, next question. Inhalational anesthetic with lowest blood gas coefficient. So, MAC was one thing which told us about potency. Another thing which we need to know about the inhalational anesthetic is their blood gas partition coefficient. Blood gas partition coefficient. Now, what do I mean by blood gas partition coefficient? See, this is the alveoli. This is surrounded by blood vessel. Now, when the agent we give, they are in alveoli. Alveoli has a partial pressure of the agent. Now, and blood has a partial pressure. When there is a pressure difference, the agent moves from high pressure to low pressure. And when the pressure becomes equal in both the medium of the agent, the movement stops. At this point, when the pressure is equal in both the medium, how the agent is divided in blood and the alveoli, that is what is blood gas partition coefficient. For example, halothane, it has blood gas partition coefficient 2.25. This means it is 2.25 times more present in blood than what it is present in alveoli at equilibrium pressure. So, to achieve the same pressure in blood compared to alveoli, more halothane has to be dissolved. So, more and more halothane is getting wasted in blood to increase its partial pressure. Now, it will be delivered to CNS because of the difference in the partial pressure. So, until and unless the pressure is raised, it will not be delivered to CNS. So, agent with high blood solubility takes more time to raise its pressure, takes more time to go to CNS. So, agent with high blood gas solubility has a slow speed of induction. Remember, agent with high blood gas solubility, right, has slow speed of induction, Agent with low blood gas solubility, okay, has fast speed of induction, So, again I would ask you to remember the sequence: halo, iso, cevo, des. Here, the blood gas solubility is decreasing in the same sequence: 2.25 of halo, 1.3 of iso, 0.63 of cevo, and 0.42 of des. As blood gas solubility is decreasing, the speed is getting faster. So, speed is getting faster. So, des is fastest, followed by cevo, followed by iso, followed by halothane. And faster than des or equal to des is nitrous oxide, which has 0.45 the blood gas solubility, and faster than them is xenon, which has blood gas solubility 0.11. Got it? So, xenon has the lowest blood gas solubility. So, the question was asked, inhalational with lowest blood gas solubility. Answer is xenon. And remember, nitrous oxide and desflurane has more or less equal blood gas solubility, 0.42. This question has also been asked recently in one of the exam, that which inhalational has a similar blood gas solubility as nitrous oxide. Answer is your desflurane, similar to nitrous oxide, got it, in speed. Okay, next question. An anesthesiology resident wanted to know about the way to decide the dose of inhalational. What determines the potency of inhalational? To understand the potency of inhalational, we need to know about their MAC. I already discussed with you. MAC is inversely proportional to the potency of the agent, right? So, if we know the MAC, we know which agent is more potent, which is less potent. So, what determines the potency? Minimum alveolar concentration, MAC. And this depends upon the lipid solubility of the agent. More the agent lipid soluble, more the agent is potent. So, potency depends upon lipid solubility of the agent. Keep it in mind. Okay. So, remember this. So, potency depends on lipid solubility. Okay. I told you about blood gas solubility. The fastest is xenon, des, nitrous oxide equal, then sevoflurane. Now, for induction, we would need to have a fast agent, right? So, technically, for potent agent, desflurane should be the induction agent of choice. But the issue with desflurane is that though desflurane is fastest among the potent agent, it is a irritant. It is a respiratory irritant. And since it is a respiratory irritant, we cannot use it for induction. Cannot be used for induction. So, which is the second fastest our agent after desflurane, the potent agent? Sevoflurane. And guys, sevoflurane is the inhalational induction agent of choice. Few important points about sevoflurane. So, I told you this is inhalational induction agent of choice. Then I told you that since it is inhalational induction agent of choice in children, we mostly go for inhalational mode of induction. It is most preferable agent in children. So it is the most preferable agent to be used in children, sevoflurane. Okay, so it gives a fast induction and also it gives a fast recovery. So it is a good agent to be used in small children. Okay, okay. Next question. A 50 years old female who is known case of diabetes, hypertension, coronary artery disease on treatment, posted for total thyroidectomy under general anesthesia. Transthoracic echocardiography showed an ejection fraction of 40%, no regional motion wall abnormalities, the inhalational anesthetic agent to be avoided in. So I would just make this question one line question. For patient with cardiovascular comorbidity, which inhalational agent should not be used? And I would add one more question, which is the agent of choice. So inhalational agent not used in cardiovascular comorbidity. 4 important agent is what we have to consider: halothane, isoflurane, sevoflurane, desflurane. Halothane is most cardio unstable. It is most cardio unstable. So halothane is something we avoid in patient with cardiovascular comorbidity. So here answer has to be halothane. Now if the same question was inhalational anesthetic agent of choice, what should be the answer? So remember, isoflurane is most cardiostable, followed by sevo equal to desflurane. So we would prefer, if agent of choice has been asked, I would have answered isoflurane, right? Better sevo equal to desflurane. So this should be the answer for cardiovascular question pertaining to cardiovascular system. Okay, halothane is bad for cardiovascular system. It's arrhythmogenic, it decreases cardiac output, it decreases blood pressure. It is bad for cardiovascular system. Keep it in mind. Okay, next. A 40-year-old male, known asthmatic, on treatment a case of sigmoid volvulus, posted for laparotomy under general anesthesia. So patient who is a known asthmatic is posted for sigmoid volvulus. Propofol was used for induction. Endotracheal intubation was facilitated by succinylcholine, and anesthesia was maintained by oxygen, sevo and cisatracurium. During intra-op period, nitrous oxide is avoided because, okay, so this is a very simple question. Absolute contraindication of nitrous oxide. What are the absolute contraindication of nitrous oxide? Now, nitrous oxide should be avoided in certain clinical condition because of some important clinical feature of nitrous oxide. Nitrous oxide expands air containing cavity. It expands air containing cavity. Air containing cavity. So if in body there is air containing cavity like pneumoperitoneum or pneumothorax, we need to avoid nitrous oxide because it will diffuse into that cavity. It is 35 times more soluble than nitrogen. It will diffuse into that cavity. It will expand the size of cavity. And what will happen? The mild pneumothorax would become severe pneumothorax. Similarly, if there is intestinal obstruction like sigmoid volvulus, if we give nitrous oxide, it will diffuse into the segment, and what it will do? It will expand the obstructed segment. Again, it will cause dilated loops of intestine. So again, we should avoid it in intestinal obstruction. So I am writing absolute contraindication of nitrous oxide. Number 1, pneumothorax or pneumopericardium. So I would avoid it in pneumothorax and pneumopericardium. Then intestinal obstruction. I would avoid it in intestinal obstruction. Then third is, we should avoid nitrous oxide in vitreoretinal surgery because there is a risk of retinal detachment seen with nitrous oxide being used in these surgeries. We should avoid it in cochlear implant surgery. Again, it expands the air containing cavity, it will cause the rejection of the implant. Now, all these are absolute contraindication. Why? Because in these conditions, nitrous oxide expands air containing cavity. So, we should not use it. But fifth contraindication is it should be avoided in laser surgery because nitrous oxide is supporter of combustion. So, in laser surgery, there would be risk of airway fire with the use of nitrous oxide. So, here why we are avoiding nitrous oxide? Because it causes the expansion of air-filled cavity. Okay, nitrous oxide is a sympathomimetic drug. It increases blood pressure and heart rate. So, it would cause increase in heart rate and blood pressure and increase in pulmonary vascular resistance. So, these are the important side effects of nitrous oxide that we have to keep in mind. Okay, next question. Which is false regarding malignant hyperpyrexia? Now, very important topic. Malignant hyperthermia. So, very important topic is of the exam. Malignant hyperthermia or malignant hyperpyrexia, whatever you want to say. Now, what is this malignant hyperthermia or malignant hyperpyrexia? It is a perioperative complication. Perioperative complication which happens due to exposure of some anesthetic agents, right? Due to exposure of some anesthetic agents in a genetically in patient with whom have malignant hyperthermic gene, actually it's a pharmacogenetic disease. Pharmacogenetic disease, right? So, in presence of drug with gene present in person, it can get precipitated. So, what are the important drugs which can precipitate malignant hyperthermia in a susceptible individual? That is the most important question asked. The most important drug which we need to remember is succinylcholine, a depolarizing neuromuscular blocker. So, succinylcholine is the most important let's say precipitator of malignant hyperthermia. Then potent inhalational anesthetic. Potent inhalational, that is your halothane, isoflurane, sevoflurane and desflurane. Not nitrous oxide, not xenon. Then lignocaine sometimes. It can also precipitate malignant hyperthermia. Now remember, malignant hyperthermia, when it gets precipitated, it will cause hypermetabolism. Hypermetabolism in the body will cause increase in carbon dioxide and increase in the temperature of the body. That's why it's called malignant hyperthermia. But increase in CO2 is one of the first early symptoms seen in malignant hyperthermia. The treatment of choice, dantrolene. Dantrolene is the drug of choice. It stops this malignant hyperthermia. Just remember this much. Okay. So, what is false regarding malignant hyperpyrexia? Dantrolene sodium is drug of choice. It's true. Isoflurane is an absolute contraindication. Yeah, it precipitates it. Characterized by muscle rigidity, hypothermia and metabolic acidosis. Yes, because of hypermetabolism. Low end tidal CO2 is the early sign. Increase in carbon dioxide because of hypermetabolism. So remember, in malignant hypothermia, the CO2 graph increases, doubles, triples. So this is the incorrect option. So this would be the answer. Okay, next question. All of the following can cause malignant hypothermia except. So already we have discussed. These are the three drugs which can precipitate it. So isoflurane, yes. Propofol, no. Succinylcholine, yes. Desflurane, yes. So answer is propofol. Guys, malignant hypothermia gets precipitated by exposure of succinylcholine and potent inhalational. Potent inhalational, right? Agreed? So which anesthetic agent we should give in a patient susceptible to malignant hypothermia? TIVA is safe. TIVA means total intravenous anesthesia. Now, TIVA is safe in patient with malignant hypothermia. Propofol would be the agent of choice. We can safely use it in a patient with malignant hypothermia for anesthesia. Drug of choice for managing malignant hypothermia, dantrolene sodium. Anesthetic agent safe in malignant hypothermia, propofol. Keep it in mind. Okay, next question. A 30 years old female who is a case of fibroadenoma posted for excision biopsy under IV anesthesia with prosil LMA and spontaneous ventilation. She was given glycomidazolam, fentanyl and propofol, right? To facilitate the LMA insertion, after 10 minutes, spontaneous ventilation was resumed and anesthesia was maintained by oxygen, nitrous oxide and sevoflurane. This rapid recovery from propofol is due to. Okay, let me make this question one line. After giving the induction dose of propofol, the single dose of propofol, patient can regain the consciousness and ventilation in 10 minutes, in 8 to 10 minutes. So, single dose, the action is only for 8 to 10 minutes. Why? Why this is happening? So, remember, when we give IV drugs, IV anesthetic, which IV anesthetic? Thiopentone, propofol, etomidate or ketamine, any of this. When we give them IV, they have a high IV concentration. They go and accumulate in the organs like CNS. They go there, act on the GABA receptor and patient becomes unconscious. When the serum concentration decreases, it comes out of the CNS, diffuse back in the blood and goes into lesser perfused organ. Lesser perfused organ it goes and it is out of the central nervous system, but it is still in the organ in the active state. So, patient though have regained the consciousness, drug has not metabolized. So, metabolism of drug has not happened. It is only from CNS it has redistributed to other organs. So, this is because of redistribution. Because of redistribution, they on single dosing, they have a short action time. This is very important question. Keep it in mind. So, redistribution is a feature shown by IV anesthetic. That's why IV anesthetic agent for maintenance is given through infusion. Infusion pump, we load it and we give it to the patient. Got it? Next question. A 38-year-old male admitted with history of RTA. He had a posterior dislocation of shoulder. The patient was planned for closed reduction under GA. Injection glycomidazolam, propofol and succinylcholine was given. Intraoperative use of propofol does not cause. Okay, simple question. Which is not feature of propofol? Feature of propofol. Now remember guys, number of time in your exam, questions can be long. Don't get bothered. Oh God, it's a long question. I wouldn't attempt it. Questions are not long. There's a story, but one line is the only important line. Pick up that line, right? So here, which is not the feature of propofol? Pain on injection? Yes. This is a side effect, notorious side effect of propofol. Bronchodilation? Yes, it's a very good bronchodilator. More hypotension than thiopentone? Yes, it causes more hypotension than thiopentone. It is cardiovascular unstable. Okay, it can cause malignant hyperthermia. No, it is safe in patient with malignant hyperthermia. It's agent of choice. Remember guys, propofol. There are some important point of propofol which we need to know. First, it is milky white in color. Milky white in color. It resembles milk, propofol. Then, propofol has egg extract present in it, though it is not contraindicated in patient with egg allergy, but if let's say we can avoid it, right? So, just remember it has egg extract present in it. Now, this propofol, one very important thing about propofol is that it has a very fast metabolism. It undergoes very fast metabolism, right? So, it is used very good drug for daycare surgery. Propofol is a cardiovascular unstable agent. That is the only demerit of propofol. Otherwise, on most of the organ system, it is a very good agent. It's a very good bronchodilator. It is neuroprotective agent and it is metabolized by liver and kidney, but it has extrahepatic, extrarenal metabolism also. So, safe in liver and kidney dysfunction, right? Plus, it is anti-emetic. It has anti-emetic effect. Now, only one important thing which you need to remember, it can cause pain on injection, right? So, these are the important points we need to remember about propofol for the solving question. So, remember, it is safe in malignant hyperthermia. Okay, What is the primary mechanism of neuroprotective effect of thiopentone? Okay, neuroprotective effect of IV anesthetic agent, not only thiopentone. Neuroprotection. What do you want to protect your brain from? You want to protect your brain from ischemic injury. And when there is risk of ischemic injury? When cerebral blood flow is decreased. So when cerebral blood flow is decreased, there is risk of ischemic injury. So when we anticipate the cerebral blood flow is going to decrease and patient can undergo brain ischemia, what we do? We give IV anesthetic agent. IV anesthetic agent decreases cerebral metabolic oxygen requirement. So when cerebral metabolic oxygen requirement reduces at lesser cerebral blood flow, ischemia will not happen. This is the primary mechanism of neuroprotection of any drug. And thiopentone decreases the oxygen requirement of brain by 55 to 60%, highest a drug can reduce. So it is agent of choice for neuroprotection. Propofol also decreases. Most of the IV anesthetic agent decreases the oxygen requirement of brain except ketamine. Okay. So remember, the primary mechanism is decrease cerebral metabolic oxygen requirement. Though it has antioxidant effect also, it is GABA agonist, right? But primary mechanism has been asked. Whenever the primary mechanism will be asked, you have to answer only one, and the answer has to be decreased cerebral metabolic oxygen requirement. Got it? Okay, next question. Patient underwent surgery and during recovery, he was shouting and having hallucination. Which anesthetic agent was used? So, patient after recovery was shouting and having hallucination. This is called emergence delirium. Emergence delirium. That is, patient is delirious after waking up. Emergence delirium. So, because of this emergence delirium, patient is shouting and doing all sort of nonsense things. Which is the drug which has been given to patient? The most common drug causing emergence delirium is ketamine, right? Remember guys, ketamine causes after recovery visual and auditory hallucination. And because of this visual and auditory hallucination, patient becomes delirious. They start screaming and all those things. So, management is midazolam. We give midazolam to the patient. It is limiting, and patient will definitely recover after some time. But till the patient is having these hallucination, patient is delirious, we can give midazolam. So, answer is ketamine. Okay, next. A 6-year-old boy scheduled for tonsillectomy, adenectomy under GA on daycare basis. He has a history of recurrent tonsillitis, obstructive sleep apnea. The anesthesiologist decided to use IV induction agent for anesthesia. What is the most commonly used IV induction agent to be used in this patient? Okay, so guys, for daycare surgery, which is the agent of choice, it has been asked. So I have already discussed with you that propofol is best agent for daycare surgery because it goes out of the body very quickly. With propofol anesthesia, what we see when patient recovers as if they have not received any anesthesia with a crystal clear consciousness. So it has no residual effect. So that's why propofol is best for daycare surgery. It's a wonderful agent for daycare surgery. Got it? So if I'm writing IV agents, I'm comparing the IV agent where they are anesthetic agent of choice. So I'm comparing thiopentone, propofol, your etomidate, your ketamine. Okay, thiopentone, nowhere IV anesthetic agent of choice. Thiopentone is nowhere agent of choice. Thiopentone has two non-anesthetic use. It is agent of choice in neuroprotection, for neuroprotection and narcoanalysis. So, two places it is agent of choice, but no agent of choice for anesthesia. Ketamine is anesthetic agent of choice in shock patient. Why? Because it is sympathomimetic, it increases the blood pressure and heart rate of patient. Bronchial asthma. Why? Because it is best bronchodilator. Etomidate. Etomidate has one major issue, a black star point of etomidate. The black star point of etomidate is it causes adrenal gland suppression. So that's why it is not so clinically used. But there is one red star point of etomidate. It is cardiovascular stable. And because of that, it is anesthetic agent of choice in cardiovascular dysfunction, in patient with cardiovascular dysfunction. Got it? Propofol, rest everything. Propofol is anesthetic agent of choice for daycare surgery, for neurosurgery, for thoracic surgery, for pre-existing liver and kidney dysfunction, everything for else. Propofol is agent of choice for malignant hyperthermia, for porphyria. I can go on writing. So don't remember. Just remember for shock, bronchial asthma, ketamine, cardiovascular dysfunction, etomidate. Rest anything anesthetic agent of choice has been asked. Propofol would be the answer. Keep this in mind. Okay? Okay, next question. All of the following IV neuromuscular blockers can cause histamine release except. Okay, they have asked histamine releaser neuromuscular blocker. So before coming on the options, seeing the option. So your neuromuscular blocker is divided into two broad division. What are they? Depolarizing and non-depolarizing. Okay, depolarizing and non-depolarizing. Now, in depolarizing, we have only one example, that is succinylcholine. This is the only drug belonging to depolarizing. Non-depolarizing, we have two group. One is aminosteroid, and other is your benzyl isoquinoline. Benzyl isoquinoline. Okay. In aminosteroid, we have pancuronium, we have pipecuronium, right? We have vacuronium, right? We have rocuronium and rapacuronium. And rapacuronium. Okay? Okay. And in benzyl group, we have D-tubocurare, doxacurium, atracurium, cisatracurium, and mevacurium. Okay, everyone. When amino is no. No means no histamine release. So this group, no histamine release. And all the drug belonging to this group has opposite no in it. So we don't release histamine. Benzyl group, histamine releaser. They release histamine. So this group, benzyl, is cardiovascular unstable and amino is cardiovascular stable. Got it? So if I see D-tubocurare is benzyl, atra is benzyl, meva is benzyl, rocuronium is amino. So amino, no, I don't release histamine. So rocuronium is amino. So no histamine release. No histamine release. Another important thing which you need to know about rocuronium is that IV injection of rocuronium, can cause pain on injection. Once it has been asked in exam, so I have written rocuronium on IV injection can cause pain. And among clinically available non-depolarizing, rocuronium is fastest among clinically available non-depolarizing neuromuscular blocker. Overall, the fastest neuromuscular blocker is succinylcholine. Fastest onset, shortest duration. Succinyl, the depolarizing, has fastest onset, shortest duration. So this has fastest onset, shortest duration. Keep it in mind. Okay. Okay. Next question. All of the following IV neuromuscular blocker, the mode of action is competitive inhibition except. So again, a very important question on mode of action of neuromuscular blocker. guys. D. Tubocurare, atracurium, racuronium, succinylcholine. Now, as I told, they are divided into depolarizing, non-depolarizing. Now, mode of action of depolarizing, non-depolarizing differs. If this is your nerve and this is your muscle end plate, right? When the nerve is stimulated, right? When the nerve is stimulated, what happens? Acetylcholine is released in neuromuscular cleft. And on the muscle end plate, we have so many nicotinic cholinergic receptors present. Okay, this acetylcholine attaches to the receptor, and the receptor opens. This causes movement of the ions across the receptor, and this causes depolarization of the muscle end plate and muscle contraction. This is normal. When I give succinylcholine is mirror image of acetylcholine. It goes and to the neuromuscular junction, attaches to the nicotinic receptor like acetylcholine, causes the opening of the receptor, causes the muscle contraction. But acetylcholine molecule has an enzyme acetylcholine esterase present at the neuromuscular cleft, which breaks the acetylcholine molecule and take it away from the receptor. Succinylcholine doesn't have any such enzyme. So it keeps sitting on the receptor for a longer duration and keep the muscle end plate depolarized for a longer time. And that is why we get a muscle paralysis. What about non-depolarizing neuromuscular blocker? How does non-depolarizing neuromuscular blocker act? Succinylcholine, how does it act? Persistent depolarization of nicotinic cholinergic receptor. But non-depolarizing neuromuscular blocker, they do not cause the opening of the nicotinic receptor. When we give non-depolarizing, they come to the neuromuscular cleft, they compete with acetylcholine molecule, they go and sit on the receptor and do nothing. So they are antagonizing the effect of acetylcholine competitively. So they are competitive antagonist. So all of the non-depolarizing neuromuscular blocker, they are competitive antagonist. Right, all of them. And succinylcholine, the mode of action is persistent depolarization. Persistent depolarization. Got it? So remember, succinylcholine is not a competitive inhibitor. So answer has to be succinylcholine. How does succinylcholine act? It acts by, mode of action is by persistent depolarization. Persistent depolarization, right? Persistent depolarization. These three act by competitive antagonism. Competitive antagonism. Got it? Okay, next question. A 70 kg athlete is taken for surgery due to unavailability of vacuronium. Succinylcholine is given repeatedly due to unavailability of vacuronium. He is now unable to take breath and his lower limb are paralyzed even after reversal. So, patient was given succinylcholine. Succinylcholine has short duration of action, but patient is having a lower limb paralyzed and not able to breathe. Patient is still paralyzed. Patient is having a persistent paralysis after succinylcholine. And this is because of the repeated dose of succinylcholine. Then why this is happening? Succinylcholine produces paralysis. Succinylcholine produces paralysis 6 to 8 minutes. Not more than this. Maximum, okay, 10 minutes. Not more than this. But if it produces the paralysis beyond this, there could be two reasons. Number one, it could be succinylcholine apnea. Something called succinylcholine. Succinylcholine's other name is succinylcholine. Succinylcholine or succinylcholine apnea, and it could be either could be phase 2 block or succinylcholine apnea. What is succinylcholine apnea? When I give single dose of succinylcholine, and we get a prolonged apnea, it is succinylcholine apnea. Why this is happening? Because the enzyme which metabolizes succinylcholine, that enzyme is not there. So there is a deficiency of pseudocholine esterase, the enzyme which metabolizes succinylcholine, deficiency of pseudocholine esterase, or we have atypical, the wrong pseudocholine esterase. So what will happen? Succinylcholine will not get metabolized, we will get a persistent apnea. This is called succinylcholine apnea. Now enzyme is normal, but when we are giving repeated dose of succinylcholine, the receptor gets desensitized by succinylcholine and we get a prolonged effect. That is called phase 2 block. This is due to repeated dose or due to very high dose. When I give normal dose and I get a prolonged apnea, succinylcholine apnea. When I give repeated dose or a very high dose and I get a prolonged apnea, that's phase 2 block. Okay, so this patient was given more than 640 milligram of succinylcholine, which is very high. Normal dose is 1 to 1.5 milligram per kg body weight, that is 70 milligram in this 70 kg athlete. Now he is given 640 milligram, more than that repeatedly. So he is now unable to breathe. That's the reason is phase 2 block. Phase 2 block. Right, pseudocholinesterase deficiency can produce a prolonged apnea, but that would be after normal dose, single dose. Okay, keep it in mind. Okay, next question. A 10 years old female child who is a case of posted for tonsillitis, posted for tonsillectomy, she was induced with propofol and nasotracheal intubation, could not be facilitated with injection succinylcholine. Mask ventilation was resumed and nasotracheal intubation was facilitated by second dose of succinylcholine. So after giving succinylcholine, we were not able to intubate the patient. Then again we gave succinylcholine, again attempted intubation, and now we were able to put the tube or not put the tube, whatever. Now, what could be the adverse effect on the second dose of succinylcholine? The cardiovascular adverse effect. So they are asking. So answer is sinus bradycardia. See, succinylcholine is mirror image of acetylcholine. It is mirror image of acetylcholine. It is mirror image of acetylcholine, right? So when we give succinylcholine, it goes to the neuromuscular junction, produce a paralysis by acting on nicotinic receptor. But it can also go to other organs like heart, the organs of undesired effect like heart. And there we have cardiac muscarinic receptor. Now, it is mirror image of acetylcholine, so it can attach to this cardiac muscarinic receptor and can cause bradycardia, it can cause arrhythmia, right? And this accumulation at cardiac muscarinic receptor more happens on repeated dose. So, whenever we repeat a dose of succinylcholine, we always have an atropine syringe ready in our hand to manage bradycardia, right? So, remember, one of the side effects of succinylcholine is bradycardia. Okay, next question. All are the side effects of succinylcholine except. So, let us discuss side effects of succinylcholine. Now, this is a simple question because tachycardia we can see right there in the option. Succinylcholine causes bradycardia. So, this has to be the answer. So, coming on the side effect of succinylcholine. Side effects of succinylcholine, right? Coming on side effects of succinylcholine. Okay. So, succinylcholine has some typical side effects. Number one, it can produce fasciculation. Fasciculation, that is tremors because of the depolarization, because it is a mirror image of acetylcholine. So, it causes depolarization and because of that we see a fasciculation. Because of fasciculation, post-operative myalgia may be seen with succinylcholine. And because of fasciculation, succinylcholine can increase intraocular pressure, intragastric pressure, intracranial pressure, the closed cavity pressure. Then succinylcholine can, very importantly, can cause hyperkalemia. How it can cause hyperkalemia? Well, this is your nerve, this is your muscle end plate. Now, muscle end plate has the junctional receptors, nicotinic, and extrajunctional receptors also. Now, when we give succinylcholine, it can act on junctional and the extrajunctional receptor both. When the extrajunctional receptor opens, it releases potassium and this results in hypokalemia. Then succinylcholine can cause bradycardia. We have already discussed how. And it can precipitate malignant hyperthermia. Okay, so these are the important side effects of succinylcholine which we have to remember, and of course, it can even cause histamine release. Okay, so it can never cause tachycardia. Hypokalemia, yes. Intracranial pressure, yes. Intragastric pressure increases. Got it? Okay, next. In rapid sequence induction, which is the neuromuscular blocker of choice? Well, guys, we need to know a little bit about the rapid sequence intubation, rapid sequence induction intubation, right? Induction intubation. Okay, so RSI, rapid sequence induction intubation. Now, why is RSI done? RSI is a process of induction intubation done to minimize the aspiration, risk of aspiration. It is done in emergency patients who are not fully NPO, right? So, it is done in emergency surgery when patient is not NPO, right? So, when patient is not NPO, there is a risk of aspiration. What is the aim of RSI? To decrease the risk of aspiration. So, how do we do RSI? The classical RSI, as it was, let's say first time it was brought in the clinical practice, it was defined, it had 5 important steps. Number 1, pre-oxygenation was mandatory. Pre-oxygenation was mandatory. Pre-oxygenation mandatory. So, we always pre-oxygenate the patient with 100% oxygen. Number 2, IV thiopentone plus IV succinylcholine given to the patient after applying cricoid pressure. Cricoid pressure, or we call it Selleck's maneuver. This is the thyroid cartilage. Below this is the cricoid cartilage. When you press it, it presses the trachea and trachea presses the esophagus and the lumen of esophagus gets collapsed. So, by applying this cricoid pressure, right, after applying this cricoid pressure, we make the patient unconscious and paralyze the patient. Why do we apply the cricoid pressure? To minimize the risk of aspiration. Then, bag and mask ventilation is contraindicated. Bag and mask ventilation. Bag and mask ventilation is contraindicated. So, we don't do bag and mask ventilation in the patient because of the risk of aspiration. Once, for let's say 60 seconds go away, patient is paralyzed, we do laryngoscopy and intubate. Laryngoscopy plus intubate. So, why the patient has not aspirated? Because we applied the cricoid pressure and we didn't do the bag and mask ventilation. This cricoid pressure is also called Selleck's maneuver, correct? So, guys, remember that this is a step of classical RSI. And a lot of modification has been done in this. So, today we practice something called modified RSI, but you don't go into modified RSI. You remember the classical RSI. And for classical RSI, we use succinylcholine. Why we use succinylcholine? Fast onset. So, succinylcholine is agent of choice in your classical RSI. Now, rocuronium is agent of choice in modified RSI. Correct? Okay. Next. So, now coming on local anesthetic, the regional anesthesia. Guys, regional anesthesia, we use a drug called local anesthetic. So, how does local anesthetic act? What is the mode of action of a local anesthetic? A very popular question. Okay. So, how do you give local anesthetic? Let's say this is a nerve fiber, right? And on the nerve fiber, we have several voltage gated channel. One very important channel is sodium channel, right? We deposit the local anesthetic around the nerve. What does local anesthetic do? It goes and bind to the sodium channel. It can bind to the sodium channel from its inner cytoplasmic side. It cannot bind from the outer side. It can only bind from the cytoplasmic side. So, sodium channel is in resting state, activated state and inactivated state, right? It is present in various states. So, when the local anesthetic reaches the cytoplasmic side, it binds to the sodium channel in inactivated state, then only the sodium channel gets closed. It gets closed and the movement of ion across the sodium channel stops and the propagation of the nerve impulse stops. So, local anesthetic acts by inhibiting the sodium channel. What does it do? local anesthetic binds to sodium channel in inactivated state. Inactivated state. So sodium channel gets blocked and the action, or let's say propagation of the nerve impulse stops. So two questions we have solved. One, it inhibits the sodium channel and binds to the sodium channel in inactivated state. Okay. Next question. Total dose of lignocaine given for peripheral nerve block should be lower than normal in. Okay guys. Now local anesthetic is divided into two groups. Local anesthetic is divided into two groups. Ester and amide. Ester and amide. Okay. Ester local anesthetic is your cocaine, your procaine, your chloroprocaine, your benzocaine and your tetracaine. Amide is your lignocaine, your mepivacaine, your prilocaine, your bupivacaine, right? Your ropivacaine and dibucaine. Now, first question which is asked, that which is amide, which is ester. So, just see 1I and 2I. All the amides have 2I in their spelling and ester has single I. So, single I one is ester, 2I is amide. Ester local anesthetic is metabolized by pseudocholine esterase except cocaine. This is metabolized by liver. So, cocaine and amide, they are metabolized by liver, hepatic metabolism. Okay. Then, cocaine is an exceptional local anesthetic. This was the first LA to be used clinically. It's a natural coca plant extract, right? Natural LA, and it is a vasoconstrictor. Rest all LA are vasodilator. This is a vasoconstrictor. Why it is a vasoconstrictor? Because it is sympathomyomatic. It is sympathomyomatic agent. So remember, cocaine is a sympathomyomatic agent. It is a vasoconstrictor. It increases blood pressure and heart rate. Remember this? So this is very important points of cocaine. So amide is metabolized by liver. So in case of any liver dysfunction, we need to decrease the dose of amide. Otherwise, there would be risk of local anesthetic toxicity. So question, total dose of lignocaine, which is a amide LA, needs to be decreased lower than normal in which of the following? Well, in liver dysfunction. In pseudocholinesterase deficiency, we have to decrease the dose of ester LA. In acute and chronic renal failure, no need to decrease the dose of LA. We need to decrease the dose of LA in liver cirrhosis, the amide LA. Correct? So, answer is liver cirrhosis. Okay, next. A 20 years old male admitted with history of RTA. Now, patient was given lignocaine, right, for open reduction, internal fixation, the peripheral nerve blocks. The injection lignocaine with adrenaline was being used, right, to decrease the bleeding. How much is the maximum dose of lignocaine with adrenaline we can use in the patient? So, maximum safest dose of ligno plus adrenaline has been asked. Now, remember guys, that these LA, they are deposited locally. If they get absorbed systemically, what will happen? If they get absorbed systemically, they will cause LAST, local anesthetic systemic toxicity. Now, we don't want LAST to happen. So, what we do? We restrict the dose to certain amount, right? That even if the systemic absorption happens, the LAST does not happen. So, for every LA, there is a maximum safest dose. You don't need to remember for all. You just need to remember for lignocaine. So, maximum safest dose of ligno plus adrenaline, right, is very commonly asked in exam. It is 7 milligram per kg body weight. So, we can give this maximum dose to produce the adequate blockade. Okay, so keep it in mind. Next question. All are absolute contraindication of neuraxial anesthesia except. So all are absolute contraindication of neuraxial anesthesia except. What is this neuraxial anesthesia? Now guys, this is your spinal cord. This is your pia. This is your arachnoid mater, right? Now these are the, and this is the dura mater. From the spinal cord, the spinal nerves come, right? They penetrate these mater, pia, arachnoid and dura, right? This is called, these spinal nerves, they are called spinal nerve root, and then they divide and do the innervation. If I put the drug between pia and arachnoid, we call it subarachnoid anesthesia, that is spinal. And if I put the drug outside dura, we call it epidural. These two come under central neuraxial blockade, right? So spinal and epidural are central neuraxial blockade, central neuraxial blockade. Okay. By both spinal and epidural, we are blocking spinal nerve root. Now, how do we block it? We take a needle between interspinous space, go and block it, right? Put the drug in these spaces. Okay. There are certain contraindications of performing central neuraxial blockade. There are some absolute contraindication of central neuraxial blockade, which we need to remember. Absolute contraindication of central neuraxial blockade. Number 1, central neuraxial blockade is absolutely contraindicated in a patient with raised intracranial pressure. What will happen? The CSF will come with a gush, and what can happen? It can lead to herniation of the brainstem. So, raised ICT, raised intracranial pressure, absolute contraindication. Then, local infection of site. Local infection of site. If we put the needle through an infected site, the meningitis encephalitis can be caused, which can be dreadful. Now, third, hypovolemic shock. Patient in hypovolemic shock. Hypovolemic shock, these block, they cause vasodilatation and hypotension. Patient already in shock, the shock will get exaggerated. Then, patient's refusal. Patient does not want the block, we cannot force it. Then, your coagulation disorder. Coagulation disorder. These are blind procedure. If you do it in coagulation disorder, hematoma, etc. can happen. And number 6, severe heart disease. Severe heart disease. In severe heart disease, the risk is even higher, right, of hemodynamic alteration. So, we avoid neuraxial. These are the 6 absolute contraindication. Well, you can see in this, no spinal deformity or pre-existing neurological deficit is there. So, in spinal deformity, pre-existing neurological deficit, we can definitely give spinal. So, all are absolute contraindication of neuraxial anesthesia except. Patient refused, yes, absolute contraindication. Local infection of site, yes, absolute contraindication. Raised ICT, absolute contraindication. Spinal deformity, not an absolute contraindication. So, keep it in mind. Kyphosis, scoliosis make the difficult spinal, but it is not a contraindication. And this is the trick the question say. The spinal anesthesia, spinal deformity. We all think it is contraindicated. No, it's not contraindicated. Correct? Okay. Next. Which of the following local anesthetic can cause methemoglobinemia? Now guys, I gave you the list of local anesthetic. Now these local anesthetic can cause some side effects. 2 side effects are asked in exam very often. 1, local anesthetic systemic toxicity. Other, methemoglobinemia. So, benzocaine and prilocaine, these 2, they can oxidize the ferrous of hemoglobin to ferric, and they can make it methemoglobin, and that is called methemoglobinemia. So, benzo and prilo, right? So, remember, benzocaine and prilocaine, they can cause methemoglobinemia. So, in the option we have benzocaine, that will be the answer, right? What is the treatment of methemoglobinemia? We give methylene blue, a reducing agent, right? We give methylene blue, okay? A reducing agent, okay. Next, most common local anesthetic used for IVRA, intravenous regional anesthesia, IVRA. So, intravenous regional anesthesia, intravenous regional anesthesia or Baar's block or Baar's block. So, what is this intravenous regional anesthesia and Baar's block? See, intravenous and regional, two contradictory things. Regional, we give the drug locally. Then how come intravenous is regional anesthesia? Well, it is practiced in arms, extremities. What we do, we tie a tourniquet in the arm and erase the, put the tourniquet, inflate the tourniquet, double the blood pressure of the patient and cut this limb from rest of the circulation. Put it in IV cannula, give the drug into that IV cannula. That remains in this limb. Only the nerve fiber of this limb gets blocked. It will not go in the systemic circulation. So what will happen? What will happen? It will produce a regional anesthesia through systemic IV route. So we call it IVRA. This was given by Dr. August Baar, pioneer for spinal anesthesia. And so on his name, it's called Baar's block. We give the drug IV and we tie a tourniquet. There is a risk always. The tourniquet, in spite of tourniquet, the drug can go in the systemic circulation. So safest LA is what we practice and unsafest LA is what we don't practice for Baar's block. So guys, if you see this list again, I want to tell you, the safest local anesthetic is lignocaine. So this is considered safest LA. So this would be the LA of choice for Baar's block. And unsafest LA, most cardiotoxic is bupivacaine. Most cardiotoxic is bupivacaine. This is the unsafest LA. And this bupivacaine is contraindicated for IVRA. Remember, it is contraindicated for IVRA. Right? So, Baar's block, three important questions can be asked. The commonest LA we use, answer is lignocaine. Then, the LA contraindicated, the answer is bupivacaine, right? And then they ask, what are the conditions in which the Baar's block is contraindicated? Contraindication of Baar's block. So guys, Baar's block is contraindicated in certain clinical condition where we cannot tie tourniquet for that long. One is your sickle cell disease. In sickle cell disease, if you will tie tourniquet, what will happen? It will cause the local acidosis and sickling and sickle cell crisis will happen. So absolute contraindication of Baar's block is sickle cell disease. Then peripheral vascular disease, scleroderma, these are absolute contraindication of your Baar's block. Got it? So these are the contraindication of Baar's block. Okay. So most common local anesthetic used, lignocaine. Local anesthetic contraindicated, bupivacaine. Okay. 2 questions solved. Next question. Okay, we have that next question. Local anesthetic contraindicated for Baar's block. Answer is bupivacaine. This is most cardiotoxic local anesthetic. Remember, this is the most cardiotoxic local anesthetic. Okay. A 17-year-old male underwent nerve block with bupivacaine. 5 minutes after the procedure, he reports some dizziness and appears agitated. What is the best next step? I told you, 2 complications of LA we need to remember. One was methemoglobinemia, which we already discussed. Other is something called LAST, local anesthetic systemic toxicity. So we need to know about what is LAST, local anesthetic systemic toxicity. So local anesthetic systemic toxicity. If the locally deposited drug gets systemically absorbed, it causes local anesthetic systemic toxicity. And 2 organ system is primarily affected, CNS and CVS. What are the clinical features of CNS toxicity? Apprehension, perioral numbness, tinnitus, and seizure. These are the clinical features of CNS toxicity. What are the clinical features of cardiovascular toxicity? Hypotension, arrhythmia, and cardiac arrest. Arrhythmia and cardiac arrest, very important. So, whenever we give local anesthetic, if any dizziness or patient gets apprehensive, agitated, comes, immediately we stop further infusion of local anesthetic. So, immediate administration of buccal midazolam, no, this is not done. Place an order for lipid emulsion therapy. Yes, this is the treatment of choice, but this can wait at present. Place on the cardiac monitor and continuous pulse oximetry. Right. Well, we are already doing the monitoring. Wait and watch. Right. Wait and watch. Now, simple. Monitoring is what we need to do continuously. We need to do continuous monitoring, and if required, we give IV infusion of intralipid, 20% lipid emulsion. So, we continue with monitoring, right, if we have already not started put the monitor, and we give 20% intralipid emulsion. If this is not in the option, simple go for lipid emulsion therapy as an answer. I have just given this option also to make you realize that before giving a drug, monitoring is very important. That is the next best step management which we can do, followed by the lipid emulsion therapy. Got it? Okay, remember this. Next, which one of the following local anesthetic is highly cardiotoxic? Well, I have already given the answer. Bupivacaine. This is most cardiotoxic. Most cardiotoxic. This is the most cardiotoxic local anesthetic. Remember this. Okay? Okay. Regarding a patient for LSCS under general anesthesia, which of the following statement is incorrect? So, little bit let us talk about LSCS. For LSCS, we can give either spinal anesthesia, which is most common practiced worldwide, epidural anesthesia, we can give even combined spinal epidural, and we can even give general anesthesia. Okay, so all these kind of anesthesia. If I am giving the neuraxial, we need a block till T4 level. So, T4 level is what we have to do. Now, patient who are pregnant patient, pregnant patient has two major issues for anesthesia, for our concerns with anesthesia. One, their airway is difficult, right? Second, they are high risk for aspiration, high risk of aspiration. Now, both these risk precludes make us think 10 times before giving GA. I mean, why should I give GA if there is a difficult airway and risk of aspiration? So, we preferably use regional. So, but if I have to give GA, we have to take extra precaution for prevention of aspiration, and we have to be prepared for managing the airway difficulty. So, in the question, patient was under GA. Which of the following statement is incorrect? Supine hypotension can be prevented by putting wedge under right buttock. Well, every pregnant lady after, let's say, 32 weeks of or 24 weeks of pregnancy, we always, to prevent the supine hypotension syndrome, put a wedge under right buttock. So, this is right. Selleck's maneuver can prevent aspiration. So, they are high risk for aspiration. So, we practice RSI in them, Selleck's maneuver. Uncuffed ET tube. Well, uncuffed ET tube increases the risk of aspiration. We always should put cuffed ET tube. So, this is an incorrect statement. Considered as full stomach always. They are very high risk for aspiration. So, we always consider them full stomach. NPO order is same, but we consider them always full stomach, right? So, we try to avoid GA. But if we have to give GA, there are certain conditions where we have to give GA. We prepare ourselves for managing the airway difficulty, and we take all precaution for aspiration by practicing Selleck's maneuver, that is RSI, and by putting the cuffed endotracheal tube always. Got it? So, this is few things we need to know about the cesarean section, anesthesia for cesarean section. Okay, next question. A 50-year-old male is known systemic hypertensive on treatment posted for hemodidectomy under spinal. the intervertebral space below which we can enter the spinal needle. Simple. Spinal anesthesia and epidural, both I talked, are the neuraxial blockade, in which we go in the interspinal space, between interspinal space, and reach the subarachnoid space or epidural space. What are the spaces where we can practice them? Now we know in adult, spinal cord end, at lower border of L1. So spinal anesthesia can only be attempted below this to keep the margin of safety. So L2-3 is the level below which we can enter for the subarachnoid space. So the intervertebral space below which we can enter is L2-3. The best space for spinal anesthesia is your L3-4. So this is considered as best space for spinal anesthesia, L3-4. But here it is asked below which we can enter with spinal needle. Then answer is L2-3. Epidural, we can give any level. We can give thoracic epidural, we can give lumbar epidural, we can give sacral epidural. Got it? We can give at any level. Understood? Okay, next. Structures not pierced in lumbar puncture or not pierced in spinal anesthesia or subarachnoid block, whatever. So guys, this is your spinal cord. These are the spinal nerves. Okay. Now this is the pia mater. This is the arachnoid mater. This is the dura mater. Okay. Then just behind the dura mater is ligamentum flavum. Then we have, these are the spinous process. Between the spinous process is interspinous ligament. Above the spinous process is supraspinous ligament. Then we have subcutaneous fascia and we have the skin. So when we are going for lumbar puncture or spinal anesthesia, we have to enter this space, right? This space, the subarachnoid space. So we take the interspinous space, pierce the skin, subcutaneous fascia, supra-interspinous ligament, ligamentum flavum. Then we pierce the dura mater, arachnoid mater, and we enter the subarachnoid space. So I said skin, subcutaneous fascia, supraspinous interspinous ligament, ligamentum flavum, dura mater, arachnoid mater. So supraspinous ligament, yes, it is pierced. Interspinous, yes. Ligamentum flavum, yes. Posterior longitudinal ligament, no. It is not pierced. It is anteriorly present in the vertebra, attached to the vertebra, not from the posterior side. We will pierce the posterior longitudinal ligament. So this would be the answer. Okay. Okay. Next. A 65 years old male with history of coronary artery disease was diagnosed with hemorrhoids, the anesthesia modality of choice. Well, hemorrhoids will go for regional, will go for spinal. There is a special type of spinal called saddle anesthesia, saddle block, or we call saddle anesthesia. Now this is a special spinal anesthesia in which sacral nerve roots are only blocked, in which we try to block only sacral nerve roots like S1, 2 and 3. Okay. How? We make the patient in sitting position, give spinal anesthesia at the level of L3-4, keep the patient in sitting position after giving the hyperbaric drug. So the drug settles along the gravity and block only S1, S2 and S3, these sacral nerve roots. So we get a very good saddle zone anesthesia. Any procedures like hemorrhoids or rectal surgery can be easily done under it. So remember, this is your saddle block. The benefit, hemodynamic imbalance minimum, because no thoracic lumbar spinal nerve roots are blocked. So in old patient or cardiac patient, this is a very good modality to get the rectal or the anal surgery done. So answer is your saddle anesthesia, special type of spinal. Okay, next question. Very important question. So just concentrate. A 45-year-old 60 kg female with acute respiratory distress syndrome post pancreatitis Patient was not maintaining oxygen saturation, so was put on mechanical ventilation. So patient was put on mechanical ventilation. Tidal volume 450 ml, respiratory rate 12 per minute, I ratio 1:2, PEEP was 5, FiO2 was 0.8. His her ABG after an hour was pH was 7.45, PaO2 46, PaCO2 39, HCO3 24 and saturation 78%. Okay, so patient is in hypoxemia according to ABG. Well, whenever you put a patient on mechanical ventilation, what is the initial setting you do? So, if I have put my patient on assist control mode, this is one of the initial mode which we put, or SIMV mode, right? Whatever. First, we select the tidal volume. Tidal volume is normally selected 6 to 8 ml per kg body weight, maximum 10 ml per kg body weight. Okay. Then, respiratory rate, near normal respiratory rate of the patient, 12 to 16 breath per minute. Then we select the PEEP, positive end expiratory pressure. Now PEEP is selected. Normally we start with 5 mm of Hg, we can increase it. This is the basic PEEP we set. I ratio, inspiration expiration ratio. We start with 1:2. We can change according to the requirement. FiO2, that is oxygen concentration. We start with 100%, we decrease it according to the requirement. Okay. This let's say I have set, after 30 minutes, I will do ABG, and seeing the ABG report, I will manage the patient. Now in ABG, we have to see two things. We have to see the PaO2, so see the oxygenation is adequate or not, and PaCO2 and pH to see ventilation is adequate or not. If patient's PaO2 is less, then there are two ways to increase the oxygenation of the patient. What are they? By increasing FiO2 oxygen concentration and by increasing PEEP, that is positive end expiratory pressure. If patient's ventilation is getting affected, right, the CO2 is rising or pH is decreasing, acidosis is happening, then we have to improve the ventilation. And for that, we can only increase the minute ventilation, tidal volume or respiratory rate can be increased. So in our patient, it was the oxygenation which is the issue. So we have to either increase the PEEP or we have to increase the FiO2 of the patient. Now, FiO2 of the patient is already high. It is 0.8, already high towards 1. This is a toxic FiO2. So we will not increase FiO2, we will increase PEEP. So here I will increase the PEEP to 8. Now what we do for oxygenation, we titer FiO2 and PEEP. Now if FiO2 of the patient I have kept is 0.4, then the PEEP, good PEEP is 5. If it is 0.5, the good PEEP is 6. If it is 0.6, the good PEEP is 6 to 8. 0.7, 8 to 10. So we titer at what minimum PEEP and minimum FiO2. Patient can have just adequate oxygenation. So my patient had FiO2 of 0.8, right? But the PEEP was very, very less. So I would increase the PEEP rather than increasing the FiO2. Got it? Keep it in mind. Okay. ARDS patient 60 kg on ventilator with 5 cm PEEP. 360 ml tidal volume. I ratio 1:2. pH was 7.38. PaO2 50. PaCO2 35. FiO2 90. What should we do next? So again the same question. Patient has a very low PEEP, right? FiO2 is high and PaO2 is getting affected. So what we will do? We will increase the PEEP. Let's say in the same question, PaO2 was good. It was 70, 70. So I didn't have to do anything. PaCO2 was increased. PaCO2 was increased. It was 50. Then I had to increase the tidal volume, right? Or I had to increase the respiratory rate. So for ventilation, tidal volume or respiratory rate has to be increased to improve the ventilation. Got it? And we see the ABG, we get an idea what we have to change in the ventilatory setting. So remember, for ventilation, we increase either tidal volume or respiratory rate. If patient has 6 to 8 ml of tidal volume, we increase it to 10 ml per kg, right? Okay, we don't go beyond that. If patient has respiratory rate, let's say 18, maximum we can increase to 30 breath per minute. We don't go beyond that. So we titre between these two for adequate ventilation. And for adequate oxygenation, we titre between FiO2 and PEEP. Got it? How do we get an idea of ventilation? By seeing the PaCO2. Normal is 35 to 45. If it is above 45, ventilation is affected. And the pH. Normal is 7.35. It is less than 7.35, acidosis. And for oxygenation, PaO2. We have to keep it above 60. Got it? So this is what we have to follow. Okay, next. A patient presented to emergency in unconscious state. There was no pulse, CPR was started. When ECG was attached, it depicted VF. Immediate defibrillation with 200 joules biphasic energy was done. What should be done next? Remember, in shockable rhythm, after shock, immediately we do CPR. Resume compression ventilation without wasting our time. After resuming compression ventilation for 2 minutes, again we look for the rhythm. Again the same rhythm, we give shock and we resume compression and ventilation. Compression, ventilation. Got it? So keep it in mind. Okay. A patient has severe hypotension, bronchospasm, edema of upper airway after injection of a radio contrast during cerebral angiography. The most appropriate immediate management. Oh God. So what is this? 3 system is getting affected. Cardiovascular, respiratory, and let's say skin changes may also be there. Now, after giving some drug, always anaphylaxis. Anaphylaxis is what we have to consider. Anaphylaxis, hypotension is one of the presenting symptoms. Bronchospasm and airway edema, one of the presenting symptoms. So, when this kind of clinical feature after giving drug, it's anaphylaxis. And remember, drug of choice for anaphylaxis is adrenaline. So, immediately we will give epinephrine. So, remember, for anaphylaxis, the clinical features, 3 system, cardiovascular, respiratory and skin. Cardiovascular, blood pressure decreases, heart rate increases and then decreases. Okay, respiratory, bronchospasm, upper airway edema, decreased breath sound. Skin, all skin changes like erythema, your redness, everything will appear. Urticaria, anything can appear. If we see this after giving any drug or even without, I am able to delineate a drug, immediate management is your adrenaline. Adrenaline is drug of choice. We give IM 0.3 to 0.5 ml per kg body weight. We give it, right? IM. If no response, we give IV. We give 1 milligram IV bolus. Sorry, IV. 1 in 10,000. 1 in 10,000. Got it? Okay. Which of the following agent is not used to provide hypotension, induce hypotension during surgery? So this was a question which was recently asked in your exam. So I have purposefully put this question. Induced hypotension during surgery or hypotensive anesthesia. Hypotensive anesthesia. For this, we use those drugs which decrease BP and are short acting. Short acting. So what are the drugs which decreases BP and are short acting? Now we can use the nitroprusside sodium and we can use nitroglycerin. Both are short acting. We give them through infusion. We can use esmolol. Now, we can use inhalational anesthetic, increase the dose of inhalational. They cause dose-dependent decrease in blood pressure. We can use even IV anesthetic. They also cause dose-dependent decrease in blood pressure. Okay, we cannot use long-acting beta blocker like metoprolol, etc. So, let us see the options. Sodium nitroprusside, yes. Hydralazine, well, we can use, it's a vasodilator, short-acting. Mifentramin, it increases blood pressure. So, how can hypotension will be produced by it? So, this will be the answer, right? Esmolol we can use. So, you have to just see hypotensive agent which is short-acting is what we are giving. Okay, next question. A 55-year-old male presents to emergency department with sudden onset palpitation and rapid heart rate. On examination, his heart rate is 160 per minute. He has a normal blood pressure. Patient is alert, not in acute distress. The ECG shown is below. What is the appropriate next step in the management of this patient? So, patient has 160 beats per minute and the blood pressure is normal. And this is the ECG of the patient. This is the ECG of the patient, right? This is PSVT. So, what is, we can see the narrow QRS complex and very rapid rate. Once a narrow QRS complex. So, this is a stable arrhythmia. I'm now revising what I have started with. Stable tachyarrhythmia. So, stable tachyarrhythmia, we will give drugs. This is PSVT, adenosine is drug of choice. And before loading adenosine, if I am able to do vagal maneuver, I will do the vagal maneuver. Okay. So, remember this. Next. A 65-year-old patient found unresponsive on arrival. There is no palpable pulse, no return of spontaneous circulation despite resuscitation. ECG showed electrical activity without any coordinated mechanical activity. What is the most common cause of PEA in this patient? So, patient was found unresponsive. What is the most common cause of PEA? Actually, they are asking most common cause of pulseless electrical activity, right? Most common cause of pulseless electrical activity can be hypovolemia, can be embolism, can be tamponade, can be tension pneumothorax. Any of these can be the common cause of let's say pulseless electrical activity, right? So, but in this is a 65-year-old patient. The patient has no history of trauma. So, I wouldn't suspect hypovolemia. Cardiac tamponade or tension pneumothorax, no such history because of no trauma. So, pulmonary embolism is most probable cause. Now, pulseless electrical activity. We need to rule out 5 H's and 5 T's. So, what are these 5 H's and 5 T's? 5 H's and 5 T's of cardiac arrest. 5H, hypoxia, hypovolemia, hypothermia, your let's say kalemia or hyperkalemia, right? Hypoxia, hypovolemia, hypothermia, hyperkalemia and your hydrogen ion, that is acidosis. This is 5H. 5T, tension pneumothorax, tamponade, cardiac tamponade, then your thrombus, the pulmonary thrombus, the coronary thrombus are toxin. So, these are 5 T's. So, we need to rule out these 5H and 5 T's. In this old patient, pulmonary embolism seems one of the complication for pulseless electrical activity. You know, pulseless electrical activity, if you will not treat the cause, it is very difficult to reverse the patient. It's a non-shockable rhythm. Okay. Now, what type of anesthesia is required for dental surgery? Now, dental surgeries, right? Dental surgeries, what kind of anesthesia is required? Field block, nerve block, infiltration, all of the above. Now, all of the above would be the answer. These are the common form of anesthesia practiced in dental surgeries. For field block around the area of interest, in a diamond fashion, we give the local anesthetic to block the entire area of interest. For nerve block, what we give? We give the local anesthetic near the nerve and let's say nerve trunks. And for Infiltration, we give the local anesthetic near the nerve endings. So we can use nerve block, we can use the infiltration, and we can even use field block for dental surgeries. So all of the above. These three are the important ways of local anesthesia administration for dental surgeries. Okay, all of the above. If you see this image, number 1 is nerve block. We are giving the local anesthetic near the main nerve trunks. As you can see, main nerve trunks. Field block, we are giving the local anesthetic near the area in the proximity of the nerve trunks, right? Now, the nerve branches, and local infiltration near the smaller terminals, nerve endings, right? Okay. So, next question, image based question. What is the procedure being performed in the image? So, you can see the tracheal ring and we are putting a tube. So, it is tracheostomy, okay? So, tracheostomy. If this was the, let's say, thyroid cartilage, this is the cricoid, and if something was happening in between thyroid and cricoid, then it would be cricothyroidotomy. But this is in trachea we are putting, because we can see this tracheal ring. This is tracheostomy. Okay. An emergency patient was being resuscitated through primary assessment approach. A, B, C, D. What does D stands for? A, B, C, D, E. A stands for airway. B for breathing. C for circulation. D for disability. E for exposure. So, answer is disability. This is very commonly asked. So, always keep in mind airway, breathing, circulation, disability and exposure or environment. Okay. Next question. Oxygen concentration from 0.25 to 0.45 can be delivered independent of patient's breathing pattern. So, this is a revision question. Independent of patient's breathing pattern by which of the following device? So, independent of the patient breathing pattern, we have to use fixed FiO2 delivering device. So, nasal cannula is variable FiO2 delivering device. Face mask, variable. Venturi mask is fixed FiO2 delivering device. NRBM is variable FiO2 delivering device. So, what will be the answer? Venti mask. Very important. So, this independent of patient's breathing pattern. Okay. Airway resistance to flow of gases through ET tube is due to. So, all can cause airway resistance, diameter, length, curvature, material, but the most common is diameter. This is the cross section of trachea through which the air will pass in unintubated person. But in intubated person, this is the cross section through which the air will pass. So, resistance is inversely proportional to the radius power 4. So, radius decreases, that is diameter decreases, the resistance increases, increased airway resistance. Okay. All of the following are component of quick SOFA, right? Quick SOFA is way of assessment of sick patient, whether there will be high morbidity mortality in them or not. And quick SOFA is a bedside tool in which there are three things we see: the blood pressure of the patient, we see the respiratory rate, and we see the GCS. Okay. So, respiratory rate, systolic blood pressure and GCS, not the heart rate. So, heart rate is not the component of quick SOFA. So, it uses three criteria, giving 1 points for lower blood pressure, high respiratory rate more than 22 and altered mentation GCS less than 15. Score ranges from 0 to 3, 1 point for each. Presence of 2 or more, there is a high risk of death and prolonged ICU stays. Just a prognostic indicator. Not, I mean, it was when it came, it was very popular, but at present it has lost its popularity because it is not showing that good clinical correlation. Okay. In neonates, resuscitation, positive pressure ventilation is given with FiO2. In neonate, if you give, normally in cardiac arrest, we give 100% oxygen. But in neonate, when you are resuscitating them, if you will use 100% oxygen, then the risk of retinopathy or prematurity is there. So, in them, we target our oxygen concentration according to the SpO2 probe which we have attached. So, we can even start the resuscitation with the room air, 21%. And we can increase if the patient is not improving, the heart rate is not improving, right? So, we can start with 21%. We can increase our oxygen concentration according to the SpO2, right? The saturation probe. So, if you see this, if 1 minute after after the birth, if the preductal saturation, the target is 60 to 65%, 2 minutes 65 to 70%, 3 minutes 70 to 75%, 4 minutes 75 to 80%, 5 minutes 80 to 85, 10 minutes 85 to 95. If it is less than this target, then only we increase the oxygen concentration. Otherwise, we just ventilate with the ambu bag at room air oxygen concentration, right? So this is the algorithm for managing a neonate in, let's say, neonate in compromised state. So at birth, if the child has term gestation good tone, child is sent to the mother. If not, child is maintained in a warm environment, secretions are cleared and little stimulus is given. If still in apnea or gasping, heart rate below 100, then positive pressure ventilation is started with the ambu bag and SpO2 probe is attached. If heart rate is still below 100, even after positive pressure ventilation, then we start the chest compression. If still below 100 the heart rate, then we give the drugs, the adrenaline, etc., and we intubate the patient. We intubate and give the drugs. So in children, newborn, first we have to take care of ventilation, and the heart rate is the best indicator whether the patient is improving or not. If heart rate remains below 100, then we go on escalating our management. Otherwise, we continue doing the management which we are doing. So first we stimulate. If the child does not start spontaneous breathing on stimulation, then we give positive pressure ventilation. If does not improve, we intubate, give positive pressure ventilation. Does not improve, we add chest compression. Does not improve, then we add the adrenaline and all. Got it? So this is how we maintain the child. And neonate. Saturation is according to the target SpO2 reading which we are getting. We have to keep that much saturation. We start with 21% room air, right, giving oxygen. We increase it to achieve the target. Okay, next question. Okay, what is the most common cause of hospital admission after daycare surgery? So this question is a little bit here and there. Most common cause of hospital admission after daycare surgery. This is just a question I have picked up, has been asked in recent exam. Remember, the most common cause of increased hospital stay after daycare surgery is post-operative nausea, vomiting. So incidence is more than 60%, and this is what, if we don't manage properly, can cause the admission of the patient in hospital after daycare surgery. So post-op nausea, vomiting, commonest post-op complication. So post-operative nausea, vomiting, commonest post-op complication. Next question. All of the following are required for cannulation of newborn except. Again, a recent question I have just picked up. Newborn, we would use the small 24 gauge yellow cannula. 22 gauge is for the let's say infants and young children. So 24 gauge cannula, adhesive and 5 ml syringe is required. 22 gauge would be bigger for the newborn, right? That's not the right size cannula. So that would be the answer. Okay, next question. Patient has fallen unconscious, steps done in sequence. Sequence of CPR, very important. Now, whenever someone gets unconscious, we call for help. After calling for help, we check the response in the patient, whether the patient has any response or not. No response, then we call for help, and definitely we check the pulse and breathing of the patient. The sequence, first we check the breathing and then we check the pulse, right? Then we do the chest compression. We start with chest compression if both is not there, and then bag and mask ventilation. So we check the response first, then we check the pulse or the, let's say, breathing of the patient, breathing, and then the pulse, and then we do the chest compression and then bag and mask ventilation. So this would be the answer, right? This would be the answer. Okay, sequence is very important. Keep sequence in mind. Breathing is first checked, then pulse. We try to check today everything together. But if it is given separately, breathing first, then pulse. Okay. Otherwise, we do it simultaneously. We do it simultaneously. Okay. So these are all questions which I wanted to discuss. Now, I have covered extensively the entire portion with whole lot of questions. If we just go through these questions, I hope you will not miss a question in exam. My best of luck for your exam. Be brave, do good for your exam. Best of luck.